Mixed cannulae, expanding performance standards. High-performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Perceval, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP venous cannula and the EZ-Flow Duo. For arterial direct and venous femoral cannulation, the EZ-Flow aortic cannula and the WRAP are available. For venous femoral access, the LivaNova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EZ-Flow Duo cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. EZ-Flow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
The point-of-care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point-of-care testing became very clear in our organization. Many of our departments consider the EPOC device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point-of-care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. That's just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the epoch that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the epoch device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
Like all perfusion professionals today, we are busy and frequently short-staffed. Does taking time off for a conference create a burden for your teammates? Has reimbursement for your continuing education dropped? Have you priced the cost of going to a meeting lately? Registration fees, airfare, transportation and parking, hotel, and meals out? This totals up to having an out-of-pocket expense of over $2,500. And then you hope the content is good. Perfusion Education has heard your concerns. They have a simple and seamless system that works on any platform, computer, tablet, or even your phone. You can chat during the program or even phone in and be live on the air. The content, second to none. Perfusion Education is by perfusionists and for perfusionists. Create a free account and check us out today.
And good morning, everybody. Happy Saturday morning to you. Welcome to PerfWeb 35, day 3, the third in our PerfWeb 35 series. Before we get started, let me go through all my housekeeping notes, please. Our sponsors, please thank them. We appreciate them very much. LivaNova and also Siemens Diagnostics, Health and Ears. Both of them have been very generous with us, and we want to thank them. Make sure you visit their sites, learn about their products, and consider evaluating them, because I think they're very good products, and we appreciate them as sponsors of our program, or advertisers on our program, I guess would be a more appropriate statement. Social media, please make sure you like, follow, and share us on the Facebook, the Twitter, and the LinkedIn. And also subscribe to our YouTube channel under PerfWeb and give us that thumbs up. Very important, subscribe and thumbs up. And make sure you click that notifications bell so that you find out about any programs we might be airing, just without them actually being scheduled. So make sure you do that, okay? Check out our websites. We have, of course, MediWeb is the host website, but we have perfweb.us, which is where our schedule is kept, and perfusioneducation.com. Perfusioneducation.com is by far the largest, most comprehensive, and inclusive perfusion education site ever anywhere in the world. You'll find an extensive library filled with great, high-quality, evidence-based programming, and also you'll find some very interesting discussions with opinions. So it's not just very dry. Hopefully we add a particular personality to our programming that you find both interesting and engaging and want to be a part of it. We have, if you want to join our faculty or you want to be an exhibitor, you see our website address right there down below, contact@perfusioneducation.com. We would be happy to hear from you if you'd like to be a faculty member, you'd like to give a presentation. We have a very extensive faculty list. Please look, check it out. Go to perfusioneducation.com, go to PerfWeb, all the links will be there, and you can take a look at everything and be a part of this growing, it's just a growing community of very engaged perfusion professionals that want to really make an impact and make a difference for our profession and our patients. Call-in number, when you see this symbol, you see it right there on the screen, that's our phone line. If you'd like to be live on the air today, be part of the discussion, ask some good questions, you can do so there, or you can do it obviously by chatting in the YouTube chat window. You can do it with Messenger on the Facebook, and I'm not sure how you do it on Twitter, but however it gets done, you can do it there. I'm monitoring YouTube, and Magic is monitoring the Twitter and the Facebook. So I want to show you very quickly just a 30 second? About a 30-second video on our Slido poll. We have a series of poll questions up, and we'd like to get more people involved. I'll be making the Slido announcements, or in terms of the results, and giving them on Monday. So you want to try to get in and get your voice heard, because this information I think is going to be very useful for everyone, not just over this latest episode, but also it's going to be useful for whatever the next episode may be. I think the only thing that I can say with certainty is that things happen over the course of time, and something like this is likely to happen again. So be a part of it by giving us your opinion or your answers to that, so that we can give you that information and everybody can learn from each other. So here's that quick 30-second ad. Just take a look at it, and then whether you're on your phone, your laptop, your tablet, doesn't make any difference. You can go to slido.com. The instructions will be there, and you can answer the questions, and then that will register those answers into the poll results. So take a look, 30 seconds. Okay, fantastic. So make sure you do that. I'll be checking on that during the break and at the end of the program. But I don't want to report the results until Monday, if that's okay. I also want to tell you about our program today. I'm going to be giving a talk on coronavirus implications for perfusion, which is going to sort of be at exploring how it affected me and what I did, and then ultimately what the team, the group that I work with, did in order to manage this crisis. I'm assuming, I think fairly, that the experience for different people, in fact, Matt Warhoover, who happens to be the director of perfusion at Vanderbilt University, as well as he is the president of the Tennessee Perfusion State Society. And he's going to give a perspective on what he's learned so far, or what we've learned so far from his involvement in this, in particular regarding ECMO survival with COVID-19. And of course, you've all met Matt before on this program, so we're really happy to have him back. We're also going to have Dr. Samir, who is going to talk about extracorporeal cardiopulmonary resuscitation, or better known as ECPR. He has a really fascinating slide. I had a chance to look at it, and some really good information and good data on that. So, and we'll be able to ask him questions about that and other things as well. The guy's an incredibly intelligent guy that's very knowledgeable, with a tremendous amount of experience in surgery, with transplants, anesthesia, critical care, pulmonology, ventilatory support, ECPR, ECMO, all of that stuff. So we're really excited that he's a part of our program and continues to be a part of our program and support us. He really is the epitome of the resident faculty that we have. His contributions are just unbelievably tremendous and highly appreciated by myself, and I know by all of you that are watching this program. So we're going to go ahead and get started on my presentation, which is regarding the coronavirus implications for perfusion. Now, one of the things that I've been trying to avoid is to have all of this be only the whole PerfWeb series being nothing but coronavirus, but clearly it is a hot topic. It's a big deal right now. There's still a lot that we just don't know and don't understand. So I don't want to overdo it. I don't want it to only be that, because when I look online, I see nothing but just video after video after video after video being about nothing. Every discussion is about nothing but coronavirus, and certainly it's a big deal. I'm not trivializing it by any stretch of the imagination, but frankly, I think that life is continuing to go on, and I'm hoping that my talk today sheds some interesting, casts some light, shows, shines some light on what I think is really a bigger problem than what coronavirus itself ultimately ended up being for most of the country. With all of the data that I've listened to, the number of asymptomatic people that were infected asymptomatic patients is incredible. It's much, much higher, making the mortality rate much, much lower. And also, concerns about how patients or people who were workers that were known to have been infected going into places where there's the high risk category patients, and how that may have exploded the numbers the way it did. I think some of this, and I'll get into it a little more in my presentation, but I think a lot of this was just the unknown, at least that for me. And I'll talk about this on a personal level. Yes, it's a virus. It's a respiratory virus, and it carried with it some pretty serious lung, damage associated with it. But I just am not 100%. I think some of it was just that we just didn't know. We were unsure, and uncertainty and not being sure about something breeds fear. And I think that was part of the problem. There was a lot of fear. Okay, I'm sorry. I don't mean to belabor the point. Let me go on to my slides. So my experience as a perfusion business owner, and that's sort of the direction that I'm going to go with this, is as a practice manager, a business owner, a perfusionist, a clinician as well. How did I manage this? And hopefully it'll be of some value to y'all. So there was a lot of uncertainty when all of this happened. How bad is it really going to get? And I heard all kinds of stories. Some of them scared the hell out of me. I certainly was concerned, even though I wasn't seeing it yet. And I'm in Houston, okay, so keep that in mind. Not New York, I am in Houston. But I was very concerned. I was anticipating, okay, how bad can it get, and how can we plan for that? And as the government started taking more and more steps by stopping, for example, elective surgeries. That was a big step to me. And at that point, we activated our disaster plan. Now, our disaster plan for this happened to be a disaster plan that was created not long prior to that actually happening. So I'm not going to sit here in front of you all and tell you that I had the disaster plan already set up from 10 years ago anticipating this being an issue. I didn't have this as an issue at the time. But you know, we still put a plan together before the actual shutdown of many of the hospitals, and all of them really with elective cases. And of course, with the understanding or thought that we were going to just be inundated with COVID-19 patients needing ECMO. We did a lot of adjusting as each day went on, and we did a lot of evaluating as each day went on. What happened yesterday? What happened the day? What are the trends? All of that stuff. And we made adjustments to what we were doing based on what was actually happening. I think, you know, when I look back on this retrospectively, you know, what I thought was going to happen actually did happen. But that's, in my view, luck. I don't think I was a fortune teller. I just think that in this particular case, I was lucky and I was right. In fact, when Dr. Samir joins us on this next presentation, on his next talk, he owes me dinner, and I'm going to bring that up. As a matter of fact, in case you're watching, Dr. Samir, I have not forgotten. You still owe me dinner, because Houston really, thus far, and I guess anything could change, but thus far has really been spared from any unmanageable level of COVID-19 patients and infections, and the hospitals being overrun and lacking bed space, ventilators, personnel, the personnel dropping from being infected, all of that kind of stuff. But we have to worry about it, and we were certainly concerned about it. Now I can't see that, so I'm going to have to open it up on my computer. Oh no, I can see it now. Okay, so the things I knew we had to do. We had to provide high level of essential care, because perfusion, whether it be for, in the case where all the elective cases were shut down and all you're going to see is emergencies, that's when you got to be on top of your game, very, very high, because those are going to be the most difficult of all of the cases. So perfusion is a very essential element for any major hospital to have, especially if it's a level 2 trauma center, level 1 trauma center, certainly level 2 trauma center. In fact, it's required to be a level 2 trauma center. You have to have cardiopulmonary bypass capabilities. We had to be concerned about contractual obligations. We had to keep our team members safe and healthy. We were managing different hospital enacted policies. So a lot of these hospitals had policies that they were putting in place as this pandemic was evolving and as it was affecting various different communities. We had to limit the number of team members that were exposed. And the reason for that was because, for example, we had one person who happened to have been out on a cruise before there was a lockdown. Not they went on the cruise despite a lockdown, but it was timing, just bad timing. And ultimately what happened was hospitals then said, if you have been out of the country, in particular on a cruise, you cannot come to that hospital for between 2 weeks and 1 month, depending on the facility. So that took that person out for 2 weeks to 30 days, depending on the facility, hoping, of course, that they didn't contract anything and have problems associated with it, which would have extended that to a much longer period of time. Ultimately, they didn't have anything. Here, let me see those slides. I can't see that screen, so I need to be able to see the slide. Where are we here? I think I'm here. Yes, there we go. Here, I've got it on my computer now, so you won't have as much trouble. We had to, of course, so we limited the number of team members that were being exposed. So if we got a COVID patient, which we did, we said, okay, those people that initiated it, because it required 2 of them, even though they were in full PAPR suits, there was debate whether or not, if they were in PAPR suits, is that actually an exposure? So, you know, that we didn't know. There was no CDC guidance yet at the time. No other facilities were addressing the issue. So the way I viewed it was, we have to err on the side of caution. Those 2 people are going to be the only 2 people that can have any contact with that patient. Now, outside of the room, that was not going to be an issue. It's if they had to go in the room that there would be an issue, even though they would be wearing the N95 mask, it would be full PPE, all that stuff. But they would not be, we would be limiting who would go in, because we, at that time when it first happened, didn't know what a contact definition was. And that created a lot of problems, a lot of anxiety for us. As elective cases plummeted and they were shutting down a lot of surgery centers, which we do with a lot of autotransfusion work in our group as well, the very first thing that I did before I knew about the PPP, the payroll protection program that exists, the very first thing we did was went out to our bank and got a line of credit, a very big line of credit. And that was risky and concerning, but it was the right thing to do. We had to do that. We also, you know, and I'm not saying this to make myself better than anybody else, because everybody has their own reality. They have to live in their own reality, and I don't pretend to speak for everyone or what the right thing to do was. You know, everybody has a different opinion, and I respect that. But I felt very strongly from day one that we as a group feel that we have highly committed and very professional people that are loyal to this company. Our practice, we have essentially no attrition. And I like everyone that works with us. And I think most days, most everyone likes me too. Not every day, I have my moments apparently, but as we all do. But I felt very strongly that we had to be committed. And so I had made that decision that if I'm going to take this, I'm going to ride this ship to the bottom of the sea. We will not do anything. We're not going to furlough. We're not going to go rolling furloughs. We're not going to reduce compensation. We're not going to force vacations. We're not going to do any of that. In fact, in our disaster plan, it was really quite the opposite, but we're going to discuss that too. But I had to evaluate the financial impact of what this was going to be. I had to interact with administrators of smaller hospitals that may close and did close as to how are we going to manage this transition. We had to find things for the team to do that were productive or that are productive. Some of our team donated blood. Some of our team delivered food for a food bank because they weren't doing cases. We weren't doing emergencies. We had a few. But our caseload essentially went to zero. I mean, it just did. And for at least a couple of weeks, we had drib and drab here or there, and then it slowly started to come back, and it's showing signs today, or on Monday's schedule, that we're fine. We actually have scheduled hearts, 3 in one day. We're used to doing 5 to 7. but we're getting there. It's moving in the right direction. I see a light at the end of this very long, dark tunnel. And that's just, I'm an optimist. I try to stay optimistic and see the glass as half full versus half empty. But, again, that's just me. That's my personality. And that's evolved too. I had to follow the news and trends very carefully. I don't think I've ever watched, read, and listened to as much news about one topic ever in my life. And after all of that, being saturated with all kinds of different perspectives and the whole thing changing even intra-day, sometimes several times in a day, as to what is actually happening, it was very frustrating for me as a citizen and as a business owner and as a healthcare professional, all of those things. It was very frustrating at the lack of a concise, consistent message. It was all over the map. And I think history will bear that out as having been one of the biggest mistakes that was made. Way too many people had way too many opinions, and none of them were factual, or some of them were, but by luck. And I think that they did a real disservice to all of us by giving out information that just really wasn't useful, and actually made things more frightening than they probably needed to be. You have to keep positive and optimistic, and have that attitude with the, we'll call it my colleagues, but rank and file. If you're a business owner, you have employees. I try not to use that term in that way, but for the sake of this discussion today, I'll say it that way. I truly believe, and have always believed, that your team is a reflection of, or a team is a reflection of the leader. When you have a department that is dysfunctional and angry and mean and backbites each other and is subversive to another team member or other team members, you find that the leader is like that. When the leader is strong, consistent, has a positive attitude, and applauds positive things, good work, hard work, and is just positive and friendly and expects that of themselves, you find the teams will reflect that as well. So you really need to keep a positive attitude, because if I was falling apart, it would be likely they would be falling apart too. Maybe not, but I do think that seems to be the way teams operate. And I think you find that whether it's military service or you find it in sports, you find it in all kinds of things. And I did a lot of praying, and I don't pray a whole heck of a lot, but I did a lot of praying that the decisions we were making were the right decisions at the moment for what we were doing. And and like I said, we were doing several day evaluations, so that anything that looked like it may not have been the right decision, we were making adjustments at that point in time. You have to stay flexible. You have to be able to change on a dime. You can't have to have a committee to decide whether or not you should discuss what's happening, because by the time you get to that point, 3, 4, 5 things have happened, and you're making decisions based on something that's old and historical. You have to be able to change very rapidly and be, very, very malleable. Now, go to the next slide. So, special considerations. This is different than a natural disaster. A hurricane, a tornado, earthquake, you can see it. It happens and it's over. This was an infectious disease with essentially an unknown degree of virulence, an unknown degree of transmissibility, you know, how easy, how many, there was more, again, very many unknowns, but it was an infectious disease that's viral. You cannot see it. So you can't see your enemy, and you don't know how long your enemy is going to be hanging around. But all of us in medicine have a special responsibility and an oath. We had this discussion yesterday, and we talked about disasters and how medical professionals deal with that. Do you protect your family, yourself, or do you protect the patients? And, you know, look, we have a very special obligation. We need to take care of our patients. And, you know, it's troubling and it's concerning. I mean, you shouldn't put yourself, if you have to run through a fire and get, and the likelihood is slim or even 50-50 that you're going to make it on the other side of that fire to help somebody, that might not be the right decision, because you have to preserve yourself in order to be able to take care of patients when the fire gets suppressed and you can get through it or around it or whatever it may be. I understand that philosophy. You have a situation where you have to evacuate your family. Your wife is injured. You have small kids. You have to take care of your family. I understand that too. But notwithstanding your family has the capability of taking care of themselves, just the sense that you want to be there is not enough to say, I don't want to go do this because I might bring something back to my family. Don't come back to your family. You go someplace else. You get a portable trailer. You do whatever you need to do. You find some other mechanism. You isolate yourself to one room of the house. You come and you go. You do what you need to do, because I truly believe that notwithstanding, you can't let yourself be killed, and there's always circumstances that your family needs, you have to be there to protect them. Just not wanting to go because it's, I want to be home with my family, kind of that stoic thing. No, you have an oath to take care of patients. And I'm going to tell you something. If it comes to a disaster, like a mass casualty or something like that, we're perfusionists, but we're trained medical personnel. We can do a whole lot more than just turn the knobs on a pump. And we all know that. Again, I'm going to say it one last time. We have a special responsibility to patients that need us. And with exception, we need to take care of those patients. That's my view. It's my opinion. Okay, so I'm going to say that. But we are all human and have families that we love, including ourselves. The team will also be afraid and worried. They will have serious financial fears. So the team, and I was very candid with them. I talked to them, every single one of them. We're getting a loan. I told them what we were doing. I told them that if anything happens, we are all going down together. So did that eliminate their fear of being unemployed or not being able to meet their bills because there had to be a reduction in income or whatever it may be? No, of course not. It didn't completely eliminate it, but it may have reduced it some, and hopefully those messages were heard. I believe they were, and it gave people some sense of relief that we're going to get through this. You always have to have that we are going to get through this. We're bigger than this. We're tougher than this. We're stronger than this. We can do this. We will do this. And I'm going down with you. I'm not going to cut and run and let you sacrifice you for my own benefit. That's a personal decision. I think it's the right decision to make. I think a lot of people did the same thing. I'm not unique. A lot of people did the same thing, and I applaud every single one of them that did that for that decision, because it's not an easy decision. Well, it is an easy decision, but you know it's going to be painful on the back end, okay? The team should be able to look to leadership for direction and encouragement, and with very rare exception, and I say this very sincerely from my heart, with very rare exception, healthcare workers will always rise to the occasion. And I think we've seen that time and time and time again throughout the course of history, and we are seeing it now as well. So I applaud all of my healthcare colleagues who have stepped up to the plate during this pandemic disaster and have conducted themselves in such a highly professional and helpful way to those that are most vulnerable, that need us. You know, the whole thing for us, as far as the impact, came early, and that may have been why Houston was spared the way it was. Simultaneous to our first case, we had a first case, was several hospitals sending notices. I said this already, that anyone traveling out of the country may not enter their facility for between 2 to 3 weeks. What came early was our first COVID patient, so it came really early. We immediately activated our disaster plan, which included immediately canceled all vacations or time off. So everyone was on call until further notice, 7 days a week. There were no exceptions whatsoever as far as that's concerned. Restricted the number of people managing the COVID patients. We addressed that. Separated the group into teams and responsible for one hospital. So we work in several hospitals. So what we did was said, okay, we've got these two that have had, even though by CDC standards later it was deemed they did not have an exposure because they were in the PAPR suit, but we just considered them as having an exposure. They've had an exposure, they're there. If it's this hospital, it'll be these two people. If it's that hospital, it'll be these two people. So it was, if it got out of hand, it was going to be basically 12-hour shifts, you know, around the clock for as long as it was going to take to manage the situation. We absolutely eliminated any unnecessary travel to hospitals for any reason. So the little things that you have to do when you run a company and you're a private practice organization, you know what? We're not doing them. Put them to the side until this gets settled. I don't want people going out, getting on the roads, having to stop to get fuel, whatever the situation be. Go into a hospital for some reason where there's other people. Let's reduce contact as much as possible. So any unnecessary travel that did not involve direct patient care was stopped. We eased restrictions as time went on based on CDC guidance and hospital regulations. And we assessed how many cases could we actually handle. So that's sort of how our disaster plan evolved. Interestingly, for us, we didn't have nearly as much ECMO as I had anticipated. However, ICU beds, ventilators, some important medicines, toilet paper, which I think everybody had that experience, seemed to be in short supply. Miraculously, don't know how that happened. Had ECMO been used more, and it had just like patient after patient after patient I'm referring to, not just used more than we used it, but if it had really been used a lot, it would have been a near impossibility for us. The first thing that would have happened was we wouldn't have enough ECMO platforms. Some hospitals, we provide them. Other hospitals, they provide their own. Nobody had enough. And by the time it got to that point, you could not find them on the market. But you have platforms. I was concerned we were going to run out of oxygenators. How can we use the oxygenator from our pump packs for ECMO? Can we do that? How can we do it? What are the considerations? You know, it has an integrated arterial line filter, which is going to be much more thrombogenic. So how would we adjust that? Yeah, certainly we would do it, but we would adjust our heparin, obviously our anticoagulation of whatever sort we were using. in order to accommodate that, but it could be done, clearly. And then I was concerned about trained personnel. If we have ECMO in all of the hospitals and then they start putting more than one in different areas of the hospital, well, there's nobody that's going to have enough people for that. You have state licensure. Even if you took that off, you have other considerations, hospital credentialing. Well, you could eliminate that too. But if it's happening here, it's probably happening elsewhere. There just aren't enough perfusionists. I'm going to address that issue to manage what would be a major increase in the utilization of ECMO on a national level or even a regional level in a couple of regions being hit simultaneously. There just aren't enough of us in the country to do that. Once it became apparent to us that we were not going to be like New York or Lombardy, Italy, by the time it got to that point, elective case volume had gone to essentially nearly non-existent. We recommended that the team donate blood or join the Meals on Wheels. We talked about that. We refined our SOPs. So we actually made really good use of our time. Some of our team became more involved in doing educational programs, which I appreciate tremendously because I think we all have a responsibility to teach each other. And teaching can be done in a lot of different ways. You know, I think I have a platform, but I also think that I have a standing. You know, I've said this before, and I'm not trying to be braggadocious here. If you just let me, you know, if you don't mind indulging me. But you know, I have 42 years. I'm almost done with my 42nd year. I'll be starting my 43rd year in perfusion come this June 1st as a clinical perfusionist. That's over and above past my training. So I've got a lot of years of doing this and a lot of experience, and I think that experience and my perceptions of things that come from all of that experience is something that should be shared. And I think whether you're like me, an older perfusionist who's been around for a while that wants to teach, please call us up. You know, we really want to hear from you. If you're a younger perfusionist and you're really excited and you're doing some basic research stuff, or you get a really interesting case and you want to talk about that to start learning how to lecture, how to talk to an audience, becoming more comfortable in front of cameras or in front of an audience, please call us. You know, we are very inclusive. I think that I can learn from the youngest perfusionist and I can learn from the oldest perfusionist. I'm not the oldest. I'm not even the longest in here. In fact, I met a young lady the other day whose dad has been practicing for 46 years, and he's at the infirmary in Mobile. And we've talked. I'm going to talk to him again on Monday, and he wants to join us with some lectures too. And his daughter became a perfusionist as well. So I'm really proud of them, and hopefully she'll join our group. We'd like to have her, but with that said, we'll have to wait and see about that. But we stayed useful. We did things for the company, worked on our new company website that's going to be coming up, worked on this program, developed the Corona 30 programs, which are coming up for helping those people who couldn't get to a meeting or couldn't make it to something or couldn't sit through a full week. We're going to do it over 3 weeks. And we could talk more about that a little bit later. Let me go on with my slides. But implications for everyone else. And I think this is something that has been lost, has been missed, and something that I am personally very concerned about, okay? So what I want you to look at here is, this is a distribution of inpatient stays with and without operating room procedures by Patient Characteristics 2014. Now this recognizing 6 years ago, but it takes that long for them to process all of this data. So this was the most current that I could find from the the Agency for Healthcare Research and Quality, AHRQ. But if you look here, the number of stays, all stays for any purpose overnight, 10,115,800. If you were having a non-operating, and that was for an operating room procedure. If you were having surgery, for a non-operating room procedure, it was 25,243,000. If you look down, and that's basically about 40% of patients have surgery that stay in the hospital at least one day or overnight, okay? If you look, you'll see that, just as a point of reference, it looks like females had more than males on both fronts. Very little difference for the operating room procedures, a little bigger for the non-OR procedures without OR. But what's important is the second red box that you see there. Look at the age, 65 to 84, our at-risk group, okay, for COVID-19. 26.3% for without OR procedure, 28.2% for surgical procedures. They encompass that. We look here, you'll see that as far as operating room procedures by patient characteristics, it looks like males were 31.6%, females were 26.4%, and the difference there compared to the previous slide was that they may have more procedures, the males, but they're in the hospital a shorter period of time, which I found interesting. 26.4% female, 45 to 64 age group 32.7, 65 to 84 30. So that's essentially 63% of all operating room procedures are done on patients, again, 45 to 84. That is well within our major at-risk age group. 85 plus obviously is too, but but that was 15.5%, so that was actually a pretty high amount. Take a look here. What are the most frequent all listed operating room procedures? Well, number 4 and 5, hip replacement and PCCA or stents. And then number 10, treatment of a fractured hip. Number 14, CAB, surprising it's that low. 19, heart valve procedures, okay? And if you look at the volume, you can see that we did 201,600 cabbages in 2014, 143,600 heart valve procedures. Now you look here at this slide, and this is the top 5 most frequent all listed operating room procedures by age group. And when you look at age groups 45 to 64, 65 to 84, and 85 plus, you see that number 2, 3, and 4 consistently, or actually 2, 3, and 4 consistently are going to be PTCA, hip replacement, and spinal fusion or some kind of laminectomy, spine surgery, or whatever it may be. And that goes across all 3 of those age groups. So again, when you look at locking the society down and telling people who are having symptoms not to come to the hospital if they think they're having COVID-19 symptoms, and they're in excruciating pain because they need a hip, is that really the right thing to do? It goes back to uncertainty. It goes back to, we don't know what's going to happen, lack of messaging, and that's probably because the professionals didn't really know what was going to happen. The CDC didn't seem to really know what was going to happen. The government certainly didn't know what was going to happen, and I don't think any of us knew what was going to happen. So I'm not criticizing it, I'm just pointing it out. And then, how many patients stayed at home having angina that thought it was something else because that's all they heard was COVID, 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 and died from an MI? I mean, our cath labs were there were crickets. Where did those patients go? They're usually a flurry of activity almost every day. What's happened to those patients? It's going to be real interesting to find that out, because I think we will find it out ultimately. Okay. Here again, the most costly inpatient stays. And what's important about this? Look at 3 through 7 and number 9. Hip replacement, PTCA, cesarean sections, coronary bypass surgery, heart valve procedures, and treatment for fractured hips. Grandmom fell, broke her hip, motor vehicle accident, somebody broke their hip or dislocated, and you have to have surgery. But what that tells me is how much money did the hospitals lose? And knowing how many hospitals there are, knowing how some hospitals are megaplexes, other hospitals aren't quite so big, but there's a lot of hospitals, a lot of surgery centers that may or may not have overnight stays. I'm assuming that the bailout for the hospitals is got to have some criteria, and I don't know if same-day surgery centers qualify the same as somebody that can maybe has 4 beds and can do overnight that's called a hospital. I really don't know. But I do know that the amount of money that they gave is not enough. I don't think these hospitals have been hurt. There's no question about it in my mind. And that's going to hurt all of us. You know, we've talked about this, I've said it several times, I'm a practicing clinician. But I'm in that age group now, and I'm in the at-risk category. I'm in that age for COVID, but I'm in the age group now that I'm going to start needing services. The last thing I need is for the hospitals and the medical teams to be decimated at a time when I'm going to need them. And then, you know, we've gone to these extreme measures. We're shortening medical school. We're saying you're in your 3rd year, you're a doctor. That's it. You know, you here you go, because of this reaction that we had to this issue. Is that the right thing to do? Because those are the people that are going to be taking care of me and you. So, are we really doing the right thing here? I'm not so sure. I think that there's a part of me, and I don't want to get into a political discussion, but you know, I'm a business owner. The government is a business. We have to make good decisions. We can't afford, I can't afford to make big, major mistakes. Your company will fall apart. So, you know, a little bit concerned about how this all got handled and how we, you know, the lack of good messaging, as I said. But, you know, without casting aspersions, I think there was a tremendous amount of uncertainty. So I'll accept that. But I do think this has hurt hospitals. I don't think we should be taking people out of medical school and basically giving them a pass on their last year for the sake of flooding the market with a bunch of physicians who may or may not really have what it's going to take care of us when we need the care. I'm just worried about that. I'm not sure I agree with it. I think that needs to be reversed. That's my opinion on that. Okay, so I think perfusion, we need to do certain things. I think first, and it says survey results, that's to remind me to tell you all to do the Slido survey. Please do the Slido survey. Okay, it's important to me. Please do it. And we're going to show you that video as soon as we finish this again. As soon as we finish my talk, while we're getting Dr. Samir linked in. Perfusion needs to demand these things without exception. We need more affordable, simplified ECMO platforms. I am not at all happy with what is currently now available. I don't want a platform that's real big. I don't want a platform that costs so much money that it uses 30% or 20% of the DRG, because it's going to make delivery of ECMO care impossible, or there's going to be I know a lot of hospitals that do not provide ECMO service. I know a lot of them. They do heart surgery all day long. They do not provide ECMO. That's not because they don't think ECMO is a good tool that really works. They can't afford it. They don't have the staff for it, which gets me to my next point. We need to adopt blended programs with ECMO specialists with exceptional and ongoing training that is founded by perfusion and managed and supervised by perfusion. I think nurses are great people, extremely intelligent, very capable. I've said this a billion times. I'll say it again for the sake of this discussion here today. We're perfusionists and we consider ourselves elite, okay? For whatever reason. But a critical care nurse can be managing a patient on epi, neo, levo, lidocaine, vaso, methylene blue, bleeding, transfusing, fluid resuscitation, fibrillating, pacemaker, ventilator, and on ECMO, and still having to provide human care to the patient, washing them, cleaning, changing their linens, along with managing all of that. And that's just the tip of the iceberg, because they manage a whole lot more than just that. They're in renal failure. Now they got to run CRRT. You just go on down the list. It's a madhouse. And I've seen one nurse manage all of that. I think optimally it should be two, and usually others will help. But I've seen one nurse manage all of that. If you can do that, I can teach you how to be an ECMO specialist. And that is going to, that's basically going to recruit into the Army, into the ranks of those people qualified to monitor an ECMO system that is stable, VV or VA, if they're stable, and provide oversight, continued training, rounds, maybe do the initial insertions until the patient is stable, or manage it if it's unstable, so they can manage the patient, working together as a team. Telemedicine now has become a big deal. And Dr. Samir, who's going to be coming on, happens to be a telemedicine expert, tele-ICU, and he'll be addressing this as time goes on, because this is not going to go away. But we could be doing the same thing. He could be sitting monitoring 4, 6, 10 ECMO patients around the country from a single command center. Him and his team could be doing that. And if there's an issue, he can say, hey, listen, I think you need to call the perfusionist on this. The circuit might need to be changed, or I think you might need some help with this, or whatever the situation may be. You know, I like to do recirculation and oxygenate a blood volume using a transonic device. I think I could teach a nurse how to do that too. But if that's what he wanted done, the perfusionist, because it's a blended program, could come in, hook that up, do it, give him the answers that he needs, and that's going to help him assess what he feels the order should be, or recommend to the primary physician taking care of that patient, intensivist or pulmonologist, what might need to be done, or as a suggestion. But you can have a surgeon, you can have a perfusionist doing that, you can have another ECMO specialist doing that. But telemedicine is very easy to do now, and it's only going to get better, because this is a big deal and it's been needed to be done for a very long time. And it's going to be exciting to see the future as that continues to take hold. We need to adopt, of course, telemonitoring, which I just said, to maximize what are very limited resources, or what is a very limited resource. I was referring to perfusion, but really it's what are limited resources, which happens to be people. You can build all the ECMO pumps you want, you can build all the oxygenators you want, but if you don't have people to manage them that know what they're doing, guess what? It doesn't matter. You can have them. They're not going to be helpful or not going to be useful or they're not going to benefit the patient. Just because you put the patient on ECMO doesn't mean that it's going to benefit the patient. You have to know what you're doing, okay? And that takes skill and experience. Okay, I think that is my final slide. So thank you very much. Yeah, that's my final slide. Thank you. And let me just put that up. So, oh, there, you're doing it. Okay, let me stop clicking it. So what we're going to do is we're going to take a 10-minute break. Oh, wait, let me see if there's any questions. Are there any questions on that end? You want to call in? You want to turn the phone line on? I don't have any questions here. No questions here that I can see. Let me refresh this screen. Do you have any questions on your end, Magic?
There's just comment. Thank you, sir, for such a conference from Dhaka.
So there were, oh, from,
Bangladesh.
so, oh, okay, good. So nice comments. We appreciate those comments very much. But the phone lines are open. So I'm going to hang out here for about 2 minutes. Oh, you know what? I don't even have to do that. Let's leave the phone line open. If somebody wants to call, we can still go to break. Just leave the phone line open. If you want to call in when we're finished with the break, then we can address your questions then as we bring Dr. Samir up. And he might even be able to have some questions of his own. So let's take a 10-minute break. Let's just do that. Yeah, run our advertisers, and we'll see y'all in 10 minutes, okay? It's exactly right at 0900 Central Time. See you then. Thank you for your attention, by the way.
Mixed cannulae, expanding performance standards. High performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Perceval, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP venous cannula and the EZ-Flow Duo. For arterial direct and venous femoral cannulation, the EZ-Flow aortic cannula and the WRAP are available. For venous femoral access, the LivaNova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EZ-Flow Duo cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. EZ-Flow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
The point of care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point of care testing became very clear in our organization. Many of our departments consider the EPOC device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point of care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. That's just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the EPOC that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the EPOC device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
Like all perfusion professionals today, we are busy and frequently short-staffed. Does taking time off for a conference create a burden for your teammates? Has reimbursement for your continuing education dropped? Have you priced the cost of going to a meeting lately? Registration fees, airfare, transportation and parking, hotel, and meals out? This totals up to having an out-of-pocket expense of over $2,500. And then you hope the content is good. Perfusion Education has heard your concerns. They have a simple and seamless system that works on any platform, computer, tablet, or even your phone. You can chat during the program or even phone in and be live on the air. The content, second to none. Perfusion Education is by perfusionists and for perfusionists. Create a free account and check us out today.
Hey everyone, and welcome back. We're going to be bringing Dr. Samir in. We got him up? Okay. Woo. Let's see. Oh, can you? I'll just ask him to turn the sound. There, he's got it. I think he's doing it. There we go. There's Dr. Samir. Hey, Doc, how are you?
How are you, sir?
It's good to see you. You look great this morning.
Thank you. You're too kind.
Of course no, I'm just being honest. So anyway, so everyone knows Dr. Samir. You've met him before. He is an incredibly talented cardiac and transplant anesthesiologist. He is an intensive care medicine expert, vent expert, and he is critical care, and also he is a telemedicine, telemonitoring, ECMO telemedicine, telemonitoring innovator, and way ahead of the curve, has been talking about this for years, and I think that's why we have a shared interest. And he's going to be talking to us today about ECPR in particular. But if any, Doc, did you see any of my presentation? And if you did you have any thoughts?
I'm sorry, sir. I did not wake up that more early. I apologize.
Oh, that hurts. That really hurts. But with that's okay. Nobody else watched it either, so I'm used to that. So with that said, I'm going to turn this over to Dr. Samir, who's going to be lecturing us today on ECPR. Dr. Samir.
I'm just making sure screen is okay.
Yeah, we see what we see is perfect.
Well, I think it's not perfect for me. There's a problem.
Mm-hmm.
Wait, do you see me now, right? Is everything okay, Joe?
It seems to be, yes. We see your slides, and you should see, you'll see me, or our studio, and we have a picture of you up. But we see your slides, and they're very clear.
Well, as long as you see my slide, I'm happy. I do not see your picture, but that's okay.
Yeah, you don't see me because they swapped cameras, but now you should see me back. I'll be back in just a second.
Okay. Well, thank you, everybody. And I miss being there in the studio, but in the age of social distancing, it's just we have to do what we have to do. And Joe, as usually, we're going to create some controversy in the morning, even we're socially distant. So please feel free to comment and disagree with me as you usually do, okay?
Yes, sir. Yes, sir. I've got my disagree button ready to go.
So the first controversial statement I'm going to make is if you do heart transplant, if you do VADs, if you do lung transplants, you have to have an ECMO program and an ECLS program. If you do any of these programs, you need to have one of these programs in place. And you need to have it in place before you start doing the heart or the VAD program. Because if you are going to put precious resources in a patient, you have to have a way to resuscitate them when they crash, and an advanced way. We're going to, obviously in the age of COVID-19, we're going to bring some new data for COVID-19 with ECPR, and you can call ECMO for COVID-19 or ECPR. Those patients are basically crashing, about to die. So you can change the name the way you want it. And it was ECPR, rapid deployment of VA ECMO, or in case of COVID-19, VV ECMO. And saving time, because we're going to see how long it takes to resuscitate somebody and bring them back. And remember, when you have a cardiac arrest, you resuscitate, you bring them back, you arrest. We're going to look at the average times and come back again. So we're going to see professional hands, how long it takes to put somebody on ECMO. And here's one of the counter, Joe, I want you to comment on that. Here, the usual code, they looked at a few codes. CPR for 10, ROSC in 10, CPR 10, ROSC in 5. That cannulation procedure would have been started, the patient would have been on ECMO with a guaranteed ROSC because we're returning the circulation. What do you think of that, Joe?
What do I think of that? I think, I mean, that seems, it seems reasonable.
Just remember, at the green zone, you have guaranteed ROSC because you're bringing the circulation back yourself. You know what I'm saying?
Yes. Yeah, I think, I think that, frankly, I think that seems pretty reasonable. You could shorten it a little bit by having having people there, an ECMO system there, not necessarily a team needed, because if your team isn't in the hospital, that time is going to be much, much longer. So, but I think that, that looks reasonable to me.
And I really have to tell you, I love the slide. And for me, when you average all the time and you see you have a code, do we have a pulse? The pulse came back. Then we lose the pulse, and then the pulse comes back. And then the outcome neurological is not the greatest. You know that, right?
Yes.
So, yeah. So, then we're going to look at the incidence of ECLS is rising up and up. And I have to tell you, we are not the most advanced in ECLS. Unfortunately, we're not. And why is that? I have no idea. There's other countries who have programs in place, and we're going to look at it, that's much more robust than we are. I think there was concerns in the beginning about ECPR and the rate of survival, and that idea was abandoned. So this is from the ELSO registry. And here's the numbers that got concerning, and that's why we reduced our ECLS. The survival to discharge was like 27% of the people. And that is 75 for respiratory, for cardiac 40, ECPR 39. The average was 27. So this is what curtailed our program. People looked at those numbers and they stopped doing ECLS. And, again, in European and Australian countries, this is part of the program. They call ahead, the team is ready, the patient comes in on the thumper, and we're going to see a video of that. Again, survivor versus non-survivor. The numbers have been improving as the years progress, as we get better at it. And like Joe said, the team has to be available in the hospital. You cannot scramble people coming from home. There has to be a call ahead. Patient gets there, and efficient CPR. And I have to tell you, efficient CPR is not manual human CPR. It's a thumper CPR. What do you think of that, Joe?
Yes, I think so. I think you're going to have more consistent effectiveness that way, and not be dependent on the strength or tiring of any individual and having to trade off. I think it has better continuity.
Absolutely. And here's what we're talking about: consistency with the CPR, consistency with the ECMO team being available. They have a cannulation strategy in their mind, ready to go, not ponder it. And different cannulation strategies work differently. And like I talked to other programs, FEM is easy for some people. In Australia, sternotomy is easy for them. And again, it's easy, and the facility and how things have worked out before for you. Okay. And again, survival rate to discharge, so many outcomes, so many different studies you can look at. And really a lot of very controversial numbers. And some of these numbers is what stopped us doing from ECLS. And you cannot look at survivor getting out today. Survivor in 6 months, survivor in 1 to 2 years. These are very important numbers. Survival with AKI. What does survival mean to all of us? Joe and I know somebody who survived and is able to continue their happy life. And there was questions, was he going to be able to do that or not? The question is, you have to look at the patient pre-ECMO status. I'm not going to say pre-ECMO status. And it was a comorbidity, so we're going to talk about that later. Any thoughts about that, Joe?
No, I think you're absolutely right. I think that the futility of care is not necessarily very very well understood. And I think that what is an acceptable life for person A may not be for person B. And I think that you, as the clinician who's making those decisions about continuing or not continuing, aren't necessarily going to know that, and you're also not going to necessarily know unless the person's been down for 10. There's some obvious reason, inadequate CPR for 20 minutes, but there's a lot of times when you simply don't know what the outcome is going to be, and so you have to consider what the patient's condition is to start with, and then base it on not only base it on data and algorithms, but you have to base it on medical experience as to how far should we take this. You're 36 years old and you go down, or 42 years old, or even 50 years old, and you've got a young family at home, you're probably going to be a lot more liberal than somebody who may be 72 years old who was bedridden and unable to walk in chronic renal failure. So I think those are things we need to take into consideration in terms of how we utilize our resources. But those are ethical questions too. But I think it just depends on the patient, Doc.
I agree with you. And look at the last two studies: survival at 24 hours, survival to discharge, survival at 3 months. That is very different numbers. You have to look at these numbers, keep them in mind.
Yes, they're huge.
Yes, I mean, they're huge differences. So I'll tell you, my controversial statement of the day: put patient on ECMO, but have an ethics consult after that to decide to continue or not. Like you always say, the problem is we put patients on ECMO and we forget about it. So I think I think you cannot ponder when the patient is coming in. Once you put them on ECMO, go ahead, but you have to decide later on and make an informed decision to continue or not.
Well, and do you mind if I throw some stuff out there?
Please do. Please do. You always do, but please do.
Yeah, and I'm curious as to how you would answer it. I would like you to answer this question because I find it troubling. It's bothersome to me. So you go in and you tell the family, look, your family member is under CPR right now. They're not going to make it if we don't put this patient on ECMO, and it's the only thing we can do right now to give them a fighting chance. And there's very few family members in that circumstance, even if they know that the patient is not really a great candidate. It's not always explained to them that directly. And so, you don't want grandma or grandpa to die. So yeah, put them on, of course, do it. But then they are the ones who are charged with making the decision to withdraw care when it becomes futile. And they just can't bring themselves to do that. And I don't know that is, I don't agree with that philosophy. I think we have to change it.
But I'll tell you here about my little opinion. I think unlike other modalities, ECMO, you have to have criteria. You have to have age criteria, comorbidity criteria. But the part that's talking to the family is like about intubation. Well, for me, if I'm going to intubate somebody, I'm going to tell the family that I don't think your mother or your father are going to be able to sustain themselves. We're going to have to put a breathing tube. And you're going to have to go over the risks and benefits and be honest about it. Some family members say, oh no, my dad never wanted that. My mother never wanted that. But I'm okay putting the tube in and then take it out the next day if the family decides they don't want to. Or they meet with ethics and they decide that that's not something that mom or dad didn't want. You know what I'm saying?
But the thing is, and certainly we have seen in this latest crisis that there's a limit to how many ICU beds, how many ventilators, we have, all of that kind of stuff becomes an issue. And I know you can put a person on a ventilator on the floor, that's not that you can't intubate somebody and put them in a recovery room or wherever, or even on a regular floor. That's a totally different issue. But ECMO is so incredibly invasive, so incredibly resource consuming. My concern is that, when you have that running like that, on somebody who really is futile care and the family is not making the decision to discontinue that care, there should be some mechanism to wean that patient off of ECMO. You gave them a shot, it's not going to work, but there are other people with much better opportunity to survive that need that technology that's available. And I know that may seem harsh or rationing of care, and I know it's an ethical dilemma, but I really do feel that way.
No, I agree with you 100%. That's why you have to have a heavy ethics involvement. I'll tell you, and I agree with rationing of care, and that's controversial, but Look at what happened in Italy. They had to do what they had to do to ration care to take care of the rest of the population. And this when there's a crisis situation, which is a cardiac arrest or a pandemic, you have to think about rationing of care. I mean, there's nothing wrong with that. I don't think that's controversial. Actually, I think that's being very realistic right now.
Yeah, we don't have unlimited resources. We really
No, we don't. But the only thing I'm biased right now. I'll tell you why I'm biased. I'm not going to elaborate any more than that. I'm biased because you've had some excellent successes, but there was very good protoplasm, for lack of a better word. With good protoplasm, you had excellent successes.
Well, you know, and I will say this too, and please forgive me. It's the last thing I'm going to say. I'm going to let you go on to your next slide. But I remember one time, and this isn't that long ago, where somebody asked me, you know, how do you think that patient's doing, or how do you think they're going to do? And I said, well, you know, and it was an elderly female, and I said, oh, yeah, I mean, to be honest with you, it was close to Thanksgiving. I said, I really think, you know, grandmom's going to be gone before the turkey's done, you know, and that was really how I felt. She walked out of the hospital.
And that's why I'm telling you, I mean, you never know. That's the problem. But you have to look at you have to go by guidance, by numbers, and by your past experiences.
Yeah, well, my past experiences and the numbers said she shouldn't have made it, but she did, and it checked me up. I was like, ooh, you know, I'm glad I wasn't the one making the decision and pulling the plug, because that would have been a horrible decision. And there's a lot of stress associated. I don't envy you and your colleagues that really do. I don't have to make that decision. You do. And I don't envy you, because that's a tough one, and it's got to haunt you at night. I don't think there's any question about that it has to.
Absolutely. And look at what happened with COVID-19. In the beginning, we thought certain age population was vulnerable. Now it turned around to be a different age population. We thought young people are immune. They're not. So things has changes, and you have to go and change with it, unfortunately.
Yes.
Here, that's ECPR criteria, and again, more controversy. Age, I think age less than 75, 100%. I mean, actually, I'm going to be a little tougher with ECPR. I'm going to put age less than 65. Okay, and that would maybe a little controversial. And shockable rhythm or not, I am not too concerned about it. And if you are, I'm not worried about ROSC, because I want you to do good ACLS. Get the patient to me, and I will put the ECMO in. Okay. Any thoughts, Joe? Stop me if you need to.
No, I'm listening, and I haven't heard anything that I disagree with.
Okay. And here is again, yeah, I think is essential. Again, in Qatar, which again is much smaller than us, therefore they have a program. With the nurses on the floor, where they have to step down for transplants, VADs, patient codes, they do not call the code team. They'll be calling right away the ECLS team. The CLS team comes to the bedside, cannulates femorally, and they go on and bring the patient to the ICU. There's no even bringing the patient to the ICU and cannulate in the ICU. It's cannulate bedside on the floor. So think about that. And I think that's a very important program if you have a transplant or assist device program.
Yeah, I can agree with that.
Now, this study, I want you, when you have a chance on your board, or you need to look at it, about those 32 patients with COVID-19.
Yeah, you sent it to me. I haven't had a chance to read it yet, but I'm looking forward to it.
You know, it's a very interesting numbers, and it's just distribution along the states. I'm gonna leave the slides flashed a little so you guys can look at it. But please, Magic or David, please let me know if I'm taking too much time.
You're not. You have plenty of time.
So I'm okay.
Yes, you have plenty.
Okay, so look at the number of ECMO according to states. Again, it's very interesting. Just to keep in mind how much COVID-19 the states have. So relate that in mind. And this is now the survival. So green, you survived. Blue, you're still going. 10, you're dead. This is from the 39 patient, from the 32 patient. I'm sorry. So this is still ongoing. This was an earlier release on Twitter. So not only the presence on Twitter, we have scientific releases on Twitter. You like that?
Absolutely, I do. I mean, I think the sooner we can get information out, the better. I just want to know that the information that's coming out on social media platforms is, you know, thoughtful information. If it's really a well done study, then I think that needs to say that. I think if it's just people's opinions, I think they need to say that too. So I'm a little skeptical of social media platforms for those kinds of announcements, because there's just not a lot of control. But if it's legit and it's appropriately referenced and a good study, I think that that's a good way to communicate real information. People just need to understand the difference. And I don't think necessarily the entirety of the general population does really understand that.
So I'll tell you, I feel right now, because of the lack of timing, you need to release your results, but do not give your opinion. Let people form their own opinion. And because all these results are going to have to be meta-analyzed later. You know, I think you should release basically a case report. You release a case reports, let the people know what you have done, what other people have done, and then you can decide to like them or not. That's I think, but recommendations should come in the conferences later. You know what I'm saying? So
Absolutely, yes, absolutely. So this slide, that slide that you just had up, that is you know, right now, I mean, VV ECMO is recognized as basically a 60-40 split. 60% survive, 40 do not. And it looks like this may be trending in that direction. Right now, it's 50-50 of those who have a completed course, with 17, which is more than double of the total. So yeah, it'll be interesting to see what happens with this. And the other thing that I would want to know from this study, and again, I have to read it, you may know already, is did they do any CVVH, aggressive CVVH? Did they do any kind of molecular adsorption for cytokine storm attenuation? You know, did they use antivirals in combination, or did they use convalescent plasma? You know, what other treatments were done, and not just the patient was put on ECMO?
I think it might be coming on a slide later.
Okay, I should have.
Okay.
I should have been patient. I'm sorry.
It's sir. I cannot guarantee it, but I think it might be coming on a slide later.
Okay.
Okay. Okay. Here, I mean, you see this slide which talks about characteristics: male, female, diabetes. So look at the diabetes, which we keep hearing about a lot. It's a 50-50 split.
Yep.
Yes. Heart disease, I mean, remember there's a lot of talk about comorbidity. Okay, 90% did not have heart disease. I mean, asthma, 100% did not have asthma. Keep that in mind. I mean, look at that. So that's, you know, these numbers you have to keep in mind and look at it. Now, here what you asked me, sir, I had it for you. I just want to surprise you, sir, so you can be proud of me. Okay, you see CRT use, okay? You see anticoagulation with heparin or argatroban. Okay, so 87% got argatroban, heparin, and 2% argatroban. Now, does the CRT use answer your question, sir?
Yes, 37% of the time it was used, and 31% unknown.
Exactly.
So the ones we know are 37% with certainty. So that's important, and 78% VV, which I would have expected. VA, VAV. You know, I don't know the reason why they used VA if they had cardiac issues on top of it.
And I think a lot. I mean, there's a lot of patients that you know, when COVID-19 attacks the myocardium, was myocarditis. and I think there was controversial how to support the heart. There's some controversy supported with Impala, supported with the VA ECMO. But I think if you're going to go on ECMO, might be the easier way to go to VA ECMO to support the heart.
Yeah, I don't like, unless you're
I know you don't like that.
Unless you're centrally cannulated, I don't. I don't like peripheral cannulation or femoral arterial cannulation with VA ECMO when you have a primary lung. In fact, I think it's a contraindication, or should be. But I'll tell you what about this slide bothers me is that there's very few of the monoclonal antibodies. I guess that's the processed convalescent plasma antibodies. Nothing on the antiviral, very little on the antivirals, very little on the hydroxychloroquine. And
it's not very little. There's like people did not get it.
They didn't get it, right. They didn't get it, exactly. That's what I mean. They're used very little.
And that's the question is, I mean, I hate to say this, that probably is very controversial, is where are you going to get your care? That's the question. Where are you going to get your care?
Well, when you can't breathe, you're going to get it at the closest hospital. And that's, again, one of the issues, because then that closest hospital may not have a relationship with a big academic medical center or the experience to manage this, and they do, you know, with all good intentions, but they just simply don't have the experience or the resources. So, I mean, I think all of those are very important points. But that really becomes a public health issue, and it becomes a need for, you know, for the public to understand it and be involved. You know, most people, Doc, think a hospital is a hospital is a hospital. I mean, that's
not true. It's not true.
Oh, I think it is. I think when you're sick and you see a hospital, you're really sick. You know, I don't. Yeah, you and I have to disagree on that. I think the overwhelming majority of the United States population feels that every hospital is going to treat you essentially the same as the next one down the street.
Well, let me tell you, for me, the most controversial number here, and you're going to be surprised, how many people got hydroxychloroquine?
Yeah, I mean, one.
Exactly. And that's a drug that's beyond cheap. Like, you can get, actually, the hydroxychloroquine is cheaper than buying candy at CVS.
Mm-hmm.
So, I mean, that's the number that bothers me the most. So, because you can say cost and availability of resources, blah, 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 blah. Like in hydroxychloroquine is like one patient, okay?
Mm-hmm.
So, as much as we hear on the news, the reality is a lot different than, than what we're looking at.
Mm-hmm. I tell you the other thing, too, that's very, I mean, I think that is very bothersome to me. But, of course, you know, we're now seeing, and I think it's political, but, you know, you may have a different opinion, I don't know, where, you know, the patients that got hydroxychloroquine in this very small observational study didn't survive. But I think that, you know, we don't know when they were given the hydroxychloroquine. Were they given it when they were, you know, taking their literally last, you know, ventilatory breaths? Their heart rhythm was disturbed and they were dying. Their lactate levels were already to 10. You know, when did they give it to them? Early intervention with either antiviral, hydroxychloroquine, the monoclonal antibodies, whatever it is, ECMO, the sooner you intervene, the more likely you're going to be to protect that patient's organ system vis-a-vis the lungs in this case, because it's a respiratory virus. And I think that's not discussed in this article, and it should have been.
I mean, remember, this article for me is an information article. Just give you what happened in the world out there.
Yeah, I don't blame.
This is going to be shocking to a lot of people.
Yeah, I'm not saying you're endorsing it or taking credit for it in any way. I'm just making it my own observation of this article. Notwithstanding, the reason you just stated you're using it for. I recognize that. I think everybody else does too.
I mean, I'll tell you what thing impressed me, because I know how much it takes effort to do. The one thing impressed me, the proning. The 62% got prone.
Yes.
Yeah.
Yes, because proning is believe it or not, it's expensive, but it's less resource consuming. I've said this in my talk earlier today. There's a lot of places, a lot of hospitals that do heart surgery. In fact, I know several of them personally that do not provide ECMO. They don't have an ECMO program, but they do heart surgery, so they can get a prone bed, but they can't just, you can get a prone bed delivered and do that a lot easier than you can just do an ECMO for your first time on a patient because you decide you want to do that. It takes it takes a lot more resources and it takes a lot more planning.
Absolutely. But again, remember, ECMO takes proning takes experience, and it can be dangerous at times if you have not done it a few times. You need to have a prone team.
Of course.
Because you can turn this patient over and everything falls out and it becomes a bigger disaster.
Yeah, the patient falls out. Then it's a real problem.
It's a much bigger disaster.
Yes.
Much bigger. So here's a little video on cannulation FEMPEM for ECPR, not just for ECMO. And again, if you're ready, you have your team ready, patient comes in, you know that you're going to do FEMPEM. You're not putzing around. Things can happen very, very quickly. I feel that. And again, it has to be with experience. The team has done it before. The team knows where the equipment is. Even the small things like ultrasound. And here they put 2 9-French sheath, so you can pass a wire in them with no problem.
Mm-hmm. What happened?
I'm trying to unfreeze it, sir. Something is frozen.
Oh.
I'm still here. I haven't left yet.
Oh. Maybe click that, see that recirc button to the left of your thing?
But it's going to play
to the left, right there? Yeah, click that.
Yes.
Yeah, now, and just let it play.
Let me, how about I take that out of it?
Mm-hmm.
And then try to just advance. Sometimes the videos get stuck.
Yeah. Mm-hmm.
And now this just shows you the cannulas, which you've seen a million times. And again, push. Don't shove too hard. You know that, Joe.
Yes, if it doesn't fit, force it. If it breaks, it was meant to be replaced anyway.
I like that. That is a very good. Can you put a little sticker with that? Bumper sticker?
Yes. That's a big hose going in there.
And again, de-airing, making sure. So you have to have your kits ready and available, and you have to have your team ready. And in Australia, they're doing it in the ER bay, and we're gonna see that. They're not even waiting for a cath lab or 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 whatever.
Mm-hmm. Yeah, we did that.
The more complicated you make it, it's not gonna work out. You're gonna be wasting time.
Yes, we did that here in Houston at a hospital that is an HCA hospital, where we had an ECPR program in the emergency department.
And here is the last stage. They're showing, which I'm sure you know very well. I was just showing for the audience.
Well, I'm gonna criticize this video.
As usual, am I surprised?
You know why?
You
know why? Because you should have asked me for this video. How many things in the body's blood vessel system, cardiovascular system, can I ask you, are square?
Sir, I know that will agitate you, and I kind of put that on purpose.
It really bothers me. Yes, it makes no sense whatsoever.
Well, remember, we're going to get to the equipment part. You can make the comment your favorites, and I'm not going to say anything. I'm going to be a good boy.
Very good.
I'm just making sure it doesn't freeze, sir. Do you know this gentleman?
Let me see when he comes up.
He's not running for president, don't worry.
Yes, I do know him. I know of him. I don't know him personally. You want to play it on our end? Okay, we're playing it.
Hello, my name is Dr. Marco Gino, the president of ELSO. The Extracorporeal Life Support Organization, ELSO, is a global non-profit organization for extracorporeal membrane oxygenation, known as ECMO, and extracorporeal life support, known as ECLS. We are working with our partners across the globe on the response to COVID-19 as it relates to the use of ECMO for supporting patients infected with the virus. We are relying on the same sources as others for information related to the evolving COVID-19 virus epidemiology. Specifically, we will continue to rely on the World Health Organization, the Centers for Disease Control, as well as local health officials and governments as the situation evolves. We remain a real-time authoritative resource because of ELSO's global member centers, which provide up-to-date information and data to allow our physicians and scientists to continually edit our recommendations. COVID-19 can cause respiratory distress in some patients. ECMO has proven to be an effective option to support selective patients with severe respiratory distress, some of which are COVID-19 patients. We are tracking this information globally, including as part of our registry. In addition, we are launching new studies and data sharing agreements with our partners across the globe. As an example, our Asia Pacific ELSO chapter is coordinating efforts across Asia Pacific region and globally to study ECMO in the treatment of patients with COVID-19. The group's trial, Extracorporeal Membrane Oxygenation for Coronavirus 19 Acute Respiratory Distress, or ECMO CARD, will study the clinical data of COVID-19 patients where ECMO treated was provided in more than 50 hospitals across 4 continents and 19 countries. This study has been endorsed by the World Health Organization and also the International ECMO Research Group, ECMO-Net. As new studies and results emerge, we will share relevant information on our website. We will be updating this information with the urgency that this situation requires. We will have a link on our homepage, www.elso.org, and also on our social media sites on Twitter, Facebook, LinkedIn, and on our ELSO ECMO Ed blog on COVID-19. We are committed to coordinating with our ECLS centers across the globe and sharing updated information as this situation warrants. Thank you very much.
I'll tell you, that's for me, it's a very impressive statement. Yeah, that you recognize that ELSO is taking COVID-19 as an ECPR situation, as you heard him talk. And I think out of this really ELSO's work, I mean, I wasn't a big believer of ELSO before more than a registry. I feel right now that they really take it this seriously, coordinating with all the other countries, because it's not important to look at our numbers. It's important to look at everybody else's.
Yes.
You know, and because we have a lot of malpractice constraints. I mean, Texas, you and I don't, but you know the Northeast, how it is, correct?
Absolutely, yes. Texas is controlling it, but you know, you're in a, believe it or not, you know, we're required to have a much higher level of insurance than the heart surgeons do here in Texas, and I think that's it's ridiculous, but it's a requirement.
So I'm telling you, we need to look at all, I mean, especially Asia, and Australia, New Zealand, England, Italy. Italy that was practicing disaster medicine. They were forced. They had no choice. So I'll tell you, so really, I'm very impressed with ELSO statement release. That's why I wanted to put it. And it's very comprehensive, that how ECMO was useful. And they felt ECMO was an ECPR methodology for COVID-19 patients. So it was like a resuscitation mechanism for them, not just an option. So that was important to me. Here's some of the numbers, you know, which those ECMO dashboard, that COVID-19 dashboards, I call it. And feel free to look at North America versus Europe versus Asia versus Latin America. What are your thoughts on the numbers? You know, I'm going to put you on the spot. You know that, right?
Well, I need to look at them.
Take your time, sir. I'm not rushing you. You say we have time. Look at that. Look at that first one on top. Was 49, 117. That's 41% discharged alive. That is the best ECMO survivor for not
Well, that says
ECL.
discharged alive or dead. That just says that just says discharged.
No, discharged alive, it says both.
No, I'm looking at the same slide. It says discharged alive and then / dead. So was that just a mistake?
Listen, we're looking at the top blue thing. Are you
Oh,
looking at the same?
discharged alive. I was looking down below. The COVID-19 counts by ELSO chapter.
Sir, you
Okay,
sir,
I'm sorry. I looked at the wrong thing. I'm sorry.
Sir, Magic and David, please keep him in line, please.
Yeah, okay.
Okay.
Yes,
So,
okay.
So that's the top line.
549, confirmed 543, and then discharged 41%. So, yeah, that's a little lower than, I mean, that's the opposite split, because that's with ECPR. Okay, this is ECPR with coronavirus. So we're not talking about VV ECMO here. We're talking VA ECMO because you have cardiovascular and pulmonary collapse.
Yeah, you're combining everything. Yes.
Okay, so those numbers are consistent. I mean, usually ECPR is, the survival on that's pretty low. I've seen it as high as 20% or so in a lot of studies.
Actually,
maybe
I'm
even
impressed
30.
with the number, to be honest with you. I think that's a good number.
41% is very high.
Yeah, that's exactly what I think it's a really very good number. I'm very impressed
for
with it.
ECPR. Yes. Okay.
Yeah.
Now we're looking at the same thing. Well, you didn't give me, you if you'd have pointed me in the right direction, I'd have gotten this right to start with. But now I know where you're looking. Yes, I agree with you 100%. That is a very impressive number for ECPR.
I mean, that's really, I have to tell you, I'm really impressed with those numbers. I mean, it does give you that now. This is all over. Remember, this different protocols, different countries. You've got to be impressed that this is the like basically the total for all these countries together. I mean, I am impressed. Here is more statistics for you to drive you crazy.
Okay.
And here's the intubation to ECMO, the median number of hours.
That's a 92 hours is a long time.
Actually, now see this. I wish you were in the studio together. I actually gonna think it's a short time. I mean, how much. Do not focus on your situation or your recent experience. Focus on other places where they stop pondering. The pondering is not good. The same discussion we had before. Put down an ECMO and then ethics consult later. That's why to shorten this number of hours. Put down an ECMO, shorten the number of hours later. So
yeah, but wait a minute. That's that sounded, and maybe I didn't understand you, but that sounded contradictory. I think 92 hours is too long to wait from intubation.
I agree.
Oh, you agree with that? Okay, yes.
Yeah,
I think
would say put them in ECMO and then ponder later.
Yeah, I think frankly, I think which way it's going by hour 48 and possibly certainly by hour 60. No,
I know absolutely. And another number that's that goes with what we're seeing. The median for the weight is 96 kilos.
Mm-hmm.
And that's and for the age, it's a little surprising. A lot of people thought it was the 50s, 60s. Look, it's 49 only.
Yes, that's low. Yes, that's young. That is young.
Absolutely. That's something, that's surprising. That's why I really love the ELSO compilation of these numbers. And they give us numbers, not just numbers for the hell of numbers. It's numbers that are important for us to understand what's going on around us. You know what I'm saying?
Agreed.
Okay. And now here's your VVA, the conversion rates. I put that just for you because I know you love that VA and then the conversion.
Yeah,
VV and then conversion.
VVVA if you need circulatory support, but the number that needed that was very low. Only 3% needed conversion, but they only had 4 that either I guess for VV, I'm looking at the VVA, but VA still, it's only 3%. And they all started off VV and then converted. So, you know, I think there was a lot of discussion, a lot of concern that there was a cardiac component. But, you know, I believe the cardiac component came from hypoxemia. And if you're waiting 92 hours as a mean to put patients on ECMO that are hypoxic, you're using, you know, of course, pressors and inotropes and all of this, you're just increasing the cardiac O2 consumption beyond its capability or its delivery and availability, and you hurt the heart. And so that's where I think the problem comes in. I think most of these cardiac complications have been secondary to basically hypoxemia. That's what I think.
American Heart Failure Society disagree with you. They feel that the hooks of the virus, you know, the virus shape we see on the news, the shape is like with hooks. They feel that the hooks attacks the myocardial cells and causes injury.
If that was the case, though, I think you would see, I mean, this 549 patients, that's a lot of people. I think if that were true, you would see a much higher conversion rate, because the conversion rate is very, very low. I mean, I just don't see it.
Well, I'm participating in a registry, and we're looking at this COVID-19 that had myocardial injury, and we'll see the results of those registries.
But you see how significant obesity is.
Yeah, amazing. I'm telling you, the numbers that we hear, they really come to fruition here.
Yes.
I mean, it's beyond. The last 3 slides is very telling about what we see around us.
But I think that, you know, I think that we see that all the time. You know, I mean, when we have a patient who has a huge abdominal area, you know, morbidly obese, and we walk into the ICU. I've done this myself many times. I know you have too, and you see the SATs lingering around 89, 90, 91, 92 maybe, and they're like, you know, we're doing everything we can. We're still on 100% on the vent. We're at, you know, as much as we can flow on the ECMO, but the patient has a good heart with a, you know, strong native cardiac output. So you're flowing 6 liters on the ECMO, but their cardiac output's 10. What's the first thing and you got high peak pressures and they're laying completely flat and they're cannulated in their neck. What's the first thing you do? And then you ponder to yourself, why hasn't somebody already done this? You raise their head of the bed up.
I have to sit them up a little.
Exactly.
I don't know why people lay flat. I think they lay because they need to lay flat all the time. I don't get it, but anyway.
And the diaphragm drops. So morbidly obese people have, just because of their physiology, I'm sorry, hold on a second, guys. I can't read it. 308 more slides. Oh, okay. Apparently, I'm talking too much. But with that said, they have already a diminished thoracic cavity and lung volume, just by virtue of their obesity.
Absolutely.
And so take advantage. That's why proning works. That's one of the reasons it works. Besides, you know, of course, also, you know, flow, gravity, taking advantage of gravity and all of that. But when you sit them up, when you raise the bed up and you drop that diaphragm, you relieve a lot of that pressure. I've seen the oxygenation come up significantly and watched the lung pressures, peak pressures, plateau pressures drop precipitously, and being able to reduce the vent, because the whole time they're like that, they're just beating the lungs up.
I agree, sir. But anyway, the numbers here are amazing, and they reflect what we've been hearing on the news. And I'll tell you what, I'm very impressed. Again, I was never impressed with ELSO before because I thought there's a registry, but I'm really impressed with their work with COVID-19.
Very good. Now listen, you have to go. I'm not allowed to. You can't ask me any more questions. I've been directed by the team over there.
Well,
I can't talk anymore.
Look at the renal failure here.
Yeah, it's high.
Yes, you think?
Very high.
Okay. So now discharge alive 41%, like we talked about before. You were that's really a very good number. Discharge.
That is, and this is this still ECPR?
Yes, sir.
Okay,
or COVID-19.
So go COVID-19, but okay. So go back one slide. Just one. One more question. That's it. I promise I won't say anything else. Go back one slide, Doc. Okay. Now look at that renal failure. What I want to know. Oh, you went too far. No, go back, go forward one slide. That one, yes, stay there.
Yes, sir, that one, sir.
Yes,
Is
with the
that-
22% renal failure, okay? That's really, really high. And so, you know, I know we've had this discussion before, and I know that you and I disagree on this at times, but I think a lot of that would be attenuated if the patient was put on, first thing is most important is oxygen delivery. Second thing, which is extremely important, I think, is inflammatory mediator attenuation. And third, I think you do that with high flow, high replacement, CVVH, and to some degree, but having molecular adsorption for cytokine storm would reduce certainly any of those things. All of those things combined will definitely decrease that renal failure rate. And I think we should do it more than we do now for that. I think there's just a lot of anxiety about how I feel about it, but I feel very strongly about it, and I think that it's just an underutilized tool, an improperly utilized tool when it is used. It's used very weakly with very low flows and using diffusive clearance only. I think they need to become much more aggressive with its use. I just don't have the authority or the power or the position to do that kind of study, but I wish somebody would, especially now with all of these patients that are being put on ECMO. But that's it. That's my last comment. So you go ahead, Doc.
Okay, so I'm just going to point something out, you know, that this all these numbers are very up to date of April 24th, 2020.
Mm-hmm.
So we're really really up to date. Contraindications to ECMO is the same contraindications that had never changed before. I mean, we all know them, and I'm not going to go over them because we all know them. And the types of ECMO, now we're going to go to the devices and types. And Joe, you need to comment. And I have a very controversial comment for you, and I know you're not going to be happy with me, but it's okay. And the difference between, everybody knows VA and VV. So those patients, COVID-19, they ended up for ECPR, I think VA is, you have to go immediately to VA. No playing around with VV for sure.
Say that one more time.
ECPR, VA ECMO directly, no VV.
Well, I agree with that. Unless, and I've seen it happen, unless the cardiac dysfunction is observed. In other words, they decompensated in front of you, and you are confident that the cardiac dysfunction is directly related to the hypoxic event that's taking place. In that case, I think VV carries with it a lot lower risk and should correct the problem immediately. And if it doesn't, then you can go VAV or VVA.
I'm going to disagree, and I said CPR, ongoing, VA, and move on with your life.
Okay, if it's CPR ongoing, then I would probably agree with that. But if the CPR, if you're standing there cannulating and the patient codes right then and there because of hypoxemia, the VV should solve the problem.
Yeah, I understand. But again, I'm very biased when the CPR is going.
Yeah.
Okay. ECPR puts the management needed. You have to manage a heart, hemodynamics, vent, sedation, temp. You don't get a neuro injury. A lot of patients leave. That's the problem with ECPR. The neurological outcome sometimes is very bad. That's the problem.
Mm-hmm. Well, how do you feel about should every patient that is ECPR and put on ECMO, should they immediately go to therapeutic hypothermia protocol?
Yes, absolutely.
Mm-hmm.
Not just yes, but absolutely. And again, if you're going to put ECPR, I mean, any of these patients on ECPR that were COVID-19, you could also consider proning them at the same time. I know people we're going to shy from that. It's controversial. It's dangerous, but I think you should do it. You know. Then again, the complications of ECMO, neurological injury is the biggest thing, and being discharged, and the worst thing is not the subarachnoid, is watershed infarcts. Watershed infarcts are responsible for your lack of function in life later on. And again, the numbers that we had talked about before, from the adult registries. I feel these numbers are going to change a lot now. These numbers are going to go up a lot more, so I'm not going to really be interested in them. Now, equipment, and the easiest, cheapest, and I know Joe is going to beat me right now. But it's okay, Joe. We're far away from each other. You cannot beat me.
Mm-hmm.
We're social distancing.
Mm-hmm.
Okay? the central mag, I'll tell you, and here is my bias is going to come in, and let me finish till the end, please. I'll tell you, I believe in the central mag because of the lack of shear forces and clots flying. And remember, so you're not really having particles rubbing against each other. So we can stop the video now. So I'll tell you one thing, is there's a case I'm very familiar with on a transplant patient. The pre-transplant crashed, and they tried to they put him on ECMO with all kinds of devices. They could not flow him high enough, and was high lactidemia, and they needed presses and all that. They switched to central mag, flowing at 8 liters, and he wasn't a big guy. Things worked out very well.
It's definitely a good tool.
So I'll tell you, I mean, they've used, cardio help, which I know is used commonly, and all that. But when they went to the center mag, they were able to flow the guy, and he was able to survive till he gets listed 1A and get his heart.
Yeah, the cardio help, I think, is I agree. The cardio help is a great tool for transport, air transport. That's really where it is most effective, and an appropriate tool. There's others, but that's an appropriate tool.
I'll tell you, I agree with you, and I wasn't a believer till I saw this case. And then the other thing I'm concerned in COVID-19 is embolic phenomena, which is very real. I'm sure you've seen a lot of videos of PEs on LinkedIn from COVID-19. So I wanted something that reduces the shear forces and doesn't throw microemboli.
Yeah. In
my little opinion, the central mag is the best at that.
Yeah, I think again, I feel like the increased thrombotic state is secondary to cytokine storm. That's really, I don't necessarily think that's unique to COVID-19.
To be honest with you, I think there's a lot of literature lately on DVT and PEs with COVID-19. And I will tell you a story. And again, cases, and I'm not going to tell you where, so do not ask me where. There's a patient that had a liver problem, has a liver issue, came in at an institution with an INR of 3 something. And which is common for liver patients, you know that.
Sure.
The team decided to overcompensate and give him FFP and straighten the INR out. Patient had a massive clot in the LAD and died the next day. And do I think it's because of the FFP? No. I think in this situation, you have to look at the INR. Yes, a liver patient, but with COVID-19, it's a hypercoagulable state, so you have to worry about that. So why is it a hypercoagulable state? I'm not smart enough to figure that. He's your favorite oxygenator. I know you love it.
Makes no sense whatsoever.
I had to agitate you, okay? I have to agitate you. And I'm sure Magic and David are happy about that. Here's from Australia.
Yeah, there's the thumper,
Yeah.
which is very useful.
So we're on a blue carry sheet here, guys. We can just go straight across on the handles. Ready for the handover? John is a 48-year-old male jogging in the park with a mate. Didn't complain of anything, just collapsed. Immediate CPR. On ambulance arrival, he's in a VFRS. He's remained refractory throughout. He's now had a total of 12 shocks. He's had 9 adrenaline and 300 of amiodarone. He's intubated with a size 6 tube, which is 22 at the teeth. Fat end tidal throughout. We don't know of any medical history. And he's also cannulated in his left hand. Lucas has been in place since the start. Initial call came in at 7:30, so that's 45 minutes since the call came in.
How long until you arrived?
We're about 6 minutes.
So we think about 6 minutes?
Yep,
Okay.
and then and so 45 minutes since the call.
Okay, that's fine. Yeah, that's all we're trying to do. Okay, I think well, let's crack on. Okay.
Man, that was a awful lot of de-airing.
I'm very impressed with their timing and their team coordination.
Well, this is what you do. They're practicing, and they're practicing so that because you usually in the real time do as you're trained. Not much flow.
You've got to be impressed by the team coordination and getting the patient on ECMO, and that's something that we should be thinking about here if you're going to do ECLS. This team needs to be working together and knows how to handle these situations and be ready once EMS comes with the patient in or on the floor. Once you get called, you cannot be looking for people. They cannot be at home. You cannot be pondering your life.
Absolutely.
You have to be able to do it and just do it and then go on and then ponder the situation later.
Absolutely agree. I couldn't agree with you more.
I mean, I'll tell you. I mean, and remember, there's another faction in Australia that zips the chest wide open. Well, that's right or wrong. That's a whole other situation. Now, one big thing that I was very impressed and I was kind of shocked about, that now the FDA is jumping into the situation, has approved ECMO as a modality, as an FDA-approved modality, which is a big statement. It's going to affect reimbursement. It's going to affect hospital, readiness. It's going to affect hospital certification. If you have an FDA-approved modality as a modality for treatment for COVID-19, as an emergency treatment for COVID-19, now if that statement come out of the FDA, it's not like now an experience anymore. That's like a drug approval. You understand what I'm trying to say?
Yes.
I mean, that's a very big thing. And I'm going to let you read the statement right there. If you have the FDA, HHS tells you this is a modality that needs to be available to treat your patients, that's going to have extreme downstream effects.
Well, it is, and again, I've been called by somebody who I don't think I'm going to be able to do anything with this, but I was called, and I thought it was odd. And I have a couple of questions actually from the online audience too. We need to get to at some point. But this person, because of this crisis, and to some degree, I think, wanting to do the right thing, but also being in a position because of the prevailing attitudes about things, is trying to develop a simplified ECMO circuit out of a dialysis machine, modifying the pump so it'll pump up to 6 liters. But I don't think they really understand, you know, how this, it's a roller pump, so it'd be a roller pump. You know, and just based on what you just said about Centromag, you know, tubing fatigue is going to be a big problem. Number one, spallation is going to be a problem, even though we have much better tubing than we used to have. But the risk for the negative and positive pressures that are going to take place are going to be very difficult. Those are challenges that need a lot of very strong electronic technical sophistication. And I don't think it's I don't really think it's a good idea. But, you know, the environment right now we're in is they're just trying to push any product onto the market. And I don't think it's, again, it's going back to my earlier discussion, which you didn't listen. But I think there's been a bit of maybe a knee-jerk reaction when, you know, there's times for that, but there's also times that you need to sort of, there are times to stop and think before you act. There's times when you should act in an emergency, but I don't think just throwing machines in the market to have a machine is a good idea, because, you know, these things can cause a lot of harm.
Well, I'm going to go back one step. I didn't want to interrupt you. Here's big statements again. A public health emergency. Devices, so they told you there's a public health emergency, and then they tell you devices in table 1 and 2, which we're going to go to, for ECMO greater than 6 hours. And I mean, now the question is this the FDA place or not? But I will tell you, I will just go through it and not make a comment. I don't want to be too political.
Mm-hmm.
And here's the device types. This, you can define that in so many different ways. But you know, I know you know more than me. Every device you have has a certain classification regulation type. And here again, a whole list of devices, and how you can make them compatible or not. There's the classification as device 1, you know, classification 1 or 2. So I wanted to bring that to your attention, that the FDA situation is getting really.
Yeah. The next question, of course, is, you know, how many of them do you need? You know, I mean, how many should we have in a hospital that has a 24-bed ICU? Should we have 24 ECMOs? Should we have 12 ECMOs? Should we, how many ECMO pumps do we need? And
hold on, boss. Let me just make you more controversy. I feel like, you know, Magic and David are going to have to stand by for you, because look at this big statement with a red under it. I mean, these are very, very profound statements that you have never seen before, and you probably would not see again unless this pandemic does not resolve. You know, again, that's a big statement. For the FDA, who's generally, remember that, FDA is very conservative. It has been for the last few years. Has not been that liberal unless recently with all the changes. So basically, they are telling you, giving you free, we're not giving all the hospitals, they can really make whatever they want to do to make a good ECMO circuit, as long as, you know, there's not going to be a patient harm. And who's going to qualitate that? You know what I'm saying?
Yes, I don't think this is a good idea. You know, I think this is a, again, I think that it is a very aggressive, not well considered set of statements that you're letting me read that bother me and concern me.
I know it would, but I'm just saying this is the realities where we live right now. You know,
but is that real? You know, well, yes, okay, understood.
I mean, but I'm just making information available.
Yes.
You know what I'm saying? And then you really have to decide. You know, I mean, and here is telling you, make modification that doesn't create undue risk of changing the coding of a device or like negative to. I mean, here's the guidelines. Is that the FDA's place? Is that or not? You know what I'm trying to say? So basically, they're telling you, you can change the devices that they approved in the past for different punks, they approved for cardiopulmonary bypass or for anything else.
Right.
You can change it into whatever it makes to do a safe ECMO circuit.
Right.
That's what they basically say.
But who makes, right. And that's the FDA's job to assure it's a safe system. Now, I think they're over-conservative. I'll be a little political. I think they're just way over-conservative, or they just take too long to make decisions, whatever the case may be. And probably politics plays a role in some of that. But, you know, you just can't throw stuff out there, you know? I mean, and just use it. You're risking doing more harm than good, and that's worrisome. So let me know when you want to get to these questions.
Okay, I'm going to make one last controversy, and you know, I'm glad I'm here. Here's what they're saying to you. They want you to use a device that you're going to move the blood from one side to the other, where you can control the speed, you can monitor the gas, and you can control the temperature. That's what the basic 4 components they want you to do.
Yep.
And that's what the recommendation. Whatever you're going to do in your garage, as long as you establish these 4 criteria, then they're good.
Yeah.
Okay?
That's,
so,
yep. I think
and
that's...
I'd like the audience, if anybody can comment on their thoughts. I mean, this is stuff, this just got published in the last 2 days.
Mm-hmm.
So, I mean...
It scares me.
I figured, and I had to put it there.
Well, how do you feel about it? What does it do for you?
I'll tell you, I came from a place in the world that's used to war medicine. I'll tell you, Joe, the practice of war medicine is very different than the practice of regulated medicine.
Mm-hmm.
Do I think we are at the place right now we need to use war medicine? I think New York was at the place we need to use. Remember, they use the expression field hospital. A field hospital. You're using the expression of having a field hospital, you're in war medicine.
Mm-hmm.
I think Italy was in a war medicine mode. I think Spain was in a war medicine mode. Mm-hmm. Should Italy and Spain be doing that? Absolutely. Mm-hmm. Should we have been doing that? In Texas, see again, the country is very fractionated. Texas is different than New York. Mm-hmm. And again, I did my training in New York, so I have a background there. But I'll tell you, we have capabilities that don't exist. Our number of ICU beds is crazy that we have available. Mm-hmm. I mean, and they have to open a field hospitals in the middle of Manhattan. Mm-hmm. And you know, so I'll tell you, war medicine, I would agree if we're practicing war medicine with the FDA. Are we at that stage? That's the question. That's really the controversy.
Yeah, I hear you. And I think that I mean, I think that if you had, what? Oh, can you stop sharing your screen?
I will try my best. That magic, I'll do my best. I mean, I'm not sure I can smart and handle it.
Do you want me to help you?
No, you helping me? I don't think so, but magic, yes.
That's
okay.
Fine.
Have I stopped magic?
Yeah. There you are. I see you now. Yes, there you're back. Being very controversial. So we have two very important questions. We have not proned our ECMO patients as of yet. Can you give advice or lessons learned, what you would do differently and safely while the patient is on ECMO and being proned? How often do you prone them? So I know what we do, but I'd like you to answer this question.
I will tell you, I mean, firstly, to prone anybody, you have to have a proning team, and that's a true proning team. That team, when you're on ECMO, has to have the nurses, obviously, respiratory, physical therapy, and the doc has to be in the room. Once the surgeon has to be in the room when you're gonna prone, and make sure you're proning care. And again, holding the tubing is like moving a patient from one area to the other. And I would prone. I would extend the proning as long as you can. I would go a minimum of 6 hours. I would go as far as 12 hours. Okay, and make sure tubes are okay, there's no kinking, that we're taping everything, that nothing is, I just be as careful as I can, especially with all the ECMO tubing. And, I would use, right now I have the luxury of using tele-ICU to monitor this patient continuously. The patient cannot be left in the room unmonitored. And you do not want to put the ECMO specialist in the room with COVID-19 the whole time. Or you do not want to put the nurse in the room the whole time. It's unrealistic. And use of PPE and too much exposure. So you're gonna have to find a way of electronic continuous monitoring of that patient. Mm-hmm. and the person monitoring will alert the outside team that they need to go in there right away. But I would do a minimum of 6, and I would go as far as 12 with no problems.
Yeah, I think proning is very beneficial.
Yeah, absolutely.
I agree with you. What we do, now we don't have the surgeon in the room when we prone. We have, and we've only proned VV patients. We haven't proned anybody on VA or even VAV. And I think it'd be very difficult to do, especially if they were centrally cannulated. I don't know. I'm not sure how that would work. So everyone that we've proned, all my experience is from a single either Avalon or Crescent catheter in the right IJ, and the lines come off the top through where the head is, and then they're draped around with a little stanchion or a support, and then come around to the ECMO circuit. And when we're proning, we have, the prone team does the turning of the bed, and we take care of just those lines. And anyone who says stop, it's stop for real. I mean, so everybody has that right to say that if necessary. And we just plan it out and do it, and we do it safely, and it's it's not hard at all to do for us. It's not hard.
How about fem? Are you okay proning fem?
I don't know. I haven't done it yet, and I think it would just depend on whether or not there was going to be, how much pressure was going to be applied, and if we could, one, if the pressure didn't occlude, I probably would be. If it did, then can I support it in some way? I just have no experience with it, so I don't know. But for VV with right IJ cannulation, it's very easy to do.
I'll tell you a little. I mean, I feel fem you can do it, and you don't have to do. Sometimes you have to be innovative. You don't have to do a full prone. You go 3/4 prone.
That's a good idea.
And the 3/4 prone with fem does work very well because you can have a space for the cannulas to come out.
That's a yes.
The key is you have to be very careful and look at the change of flow. Any change of flow, you need to stop, because it's very hard in emergency to flip back again.
Absolutely, that is very true. The other thing that I feel is that I don't ever want to be in a position where I cannot visualize all of the length of the circuit and the cannula site itself. I feel like I have to be able to physically see it and, if necessary, touch it.
I agree 100%. I'll tell you. I mean, you have to be safe, but I think it should not stop you from proning.
Agreed.
And the success with ECMO and proning has been amazing. When we've seen that, the numbers we've looked at before, with those 20 patients that got proned in the study, and they did very well. So
very good. The other question is, what about bivalrudin? This person is seeing a lot of programs just going directly to bivalrudin versus heparin. We have not done that. We use heparin as our first line unless we think there's a heparin allergy hits or whatever it may be, or it's ineffective for some reason. But we haven't used anything, but we rarely ever use anything besides heparin. That's our experience.
I'll tell you, I mean, I know, let's just be, and it's not about you guys only. I mean, realistically, people use heparin because it's cheaper and easier to manage. But there's a big move right now to use bivalrudin because there has been studies that validated less bleeding, believe it or not, with bivalrudin. And I mean, and to avoid the hit situation, because once you go into a hit situation with ECMO, it becomes really a nightmare, a huge nightmare. And the patient eventually dies from the hit part, like necrosis of their limbs and all that. And I unfortunately I've seen cases like that. But there is programs right now going to bivalrudin immediately. And I have to tell you, I wasn't supporting that, but once I see the studies that less bleeding with bivalrudin, which really shocked me, that I was thought to get be more bleeding. The question is, we have less experience with it, and it's more expensive. So you have to look at the expense part, and you have to look at the experience. But if you manage it and you have a protocol, and by the way, the bivalrudin protocols for anticoagulation for ECMO, they're all case experiences. There's not a protocol even published by the company. There has never been one. So, and I'm okay with that as long as it goes with your experience and your team knows how to use it. You have a pharmacist that rounds, you have a hematologist that backs you up, when you call them, and they will tell you how to manage if there's a problem. So I'm okay getting away from heparin. Heparin is more and more causing more problems. But I do, we've used bivalirudin very successfully, and other people have used it with no problems at all.
When you do your heparin protocol, do you like we use the SCCM guidelines of 1.5 times baseline. So we use comparatively, I think, very little heparin on our patients. You know, and keep our we don't bother measuring ACTs. We just measure APTTs, and we keep them, as I said, 1.5 times baseline. We'll go down to 1.4 or 1.3 if we have really good flow and not worry about it. We you know, rarely do we ever go much, you know, we ever really get higher than that, maybe 1.6, 1.7 times baseline, but we try to keep it really tight, and we don't really use a lot of heparin, and we don't really see a whole lot of bleeding complications associated when we use that particular methodology of heparin management.
Now, with the opposite, you have thrombotic complications.
Yeah, but we you know, again, you know, we haven't. I mean, I know hits exist, and you know, and maybe, you know, we don't do enough of them. You do a lot more of them than we do, but I mean, we do a fair amount, and I haven't seen an ECMO with hits, and I can't even remember when.
Now you unfortunately you're pushing my button, because I've seen 3 cases in the last month.
Really?
Yeah, and bad hits.
With actual white clot syndrome.
Absolutely, I would positive PF4, positive ELISA, positive everything. But I'll tell you, and we're converting the patients to argatroban really helped a lot, and bivalirudin a lot. But I mean, I'm a now proponent of using, you know, other alternative methods than heparin. And I'll tell you, I'm not that smart. Once you start patient on ECMO, let the pharmacy manage the heparin protocol. They are very good at it. They have an algorithm.
Yeah, it's probably
let them do their thing.
That's probably that's probably a really good idea. Okay, well, now are you going to be able to stay with us while Matt does his lecture, or do you need to go?
No, sir, I can stay with you.
You can stay with us?
Maybe I'll stop and have my coffee, but I will stay with you.
Yes, yeah. We're going to take can we take a 10-minute break? So we're going to take, yeah, about a 10 or 15 minute break. So we're going to take, let's just say 10. Can we do 10? Or do you need, tell me what you need.
Yeah.
10 will work?
Yeah.
Okay, so we're going to take a 10-minute break. Dr. Samir, you can get you can get your coffee refreshed. I'm going to do the exact same thing. And we'll see our audience back in about 10 minutes. So, you know, we'll say it's 10:22, so 10:32 to 10:33, we'll be going back on with Matt Warhoover, who is the Director of Perfusion Services at Vanderbilt University and also the President of the Tennessee Perfusion Society. State society, a very, very good friend of mine, incredibly bright guy. And I think you're going to really be fascinated with this, Dr. Samir, because he's going to be talking about his experience in Nashville and how all the preparation they did and where it ended up really going. Not to say the preparation didn't need to be done, but again, we're talking about how did we really respond to this, and was anything, if it really would have been Armageddon, would anything we were actually able to do have been enough? And I think it's going to be I think Matt's going to give us some really interesting perspective, and then we can ask and have some good controversial discussion. Hopefully everybody else will get involved. We'll open the phone lines up by then. Okay, with that said, 10 minutes.
Mixed cannulae, expanding performance standards. High performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Perceval, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP venous cannula and the EZ-Flow Duo. For arterial direct and venous femoral cannulation, the EZ-Flow aortic cannula and the WRAP are available. For venous femoral access, the LivaNova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EZ-Flow Duo cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. EZ-Flow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
The point-of-care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point-of-care testing became very clear in our organization. Many of our departments consider the EPOC device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point-of-care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. This is just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the EPOC that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the EPOC device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
Like all perfusion professionals today, we are busy and frequently short-staffed. Does taking time off for a conference create a burden for your teammates? Has reimbursement for your continuing education dropped? Have you priced the cost of going to a meeting lately? Registration fees, airfare, transportation and parking, hotel, and meals out? This totals up to having an out-of-pocket expense of over $2,500. And then you hope the content is good. Perfusion Education has heard your concerns. They have a simple and seamless system that works on any platform, computer, tablet, or even your phone. You can chat during the program or even phone in and be live on the air. The content, second to none. Perfusion Education is by perfusionists and for perfusionists. Create a free account and check us out today.
And welcome back, everyone. I thank you all for staying with us on your Saturday. Hopefully you're having a good time. I also want to thank, of course, our faculty. We're going to bring Matt in, Matt Warhoover. I think whenever you're ready to bring him in, I'm ready. But I want to thank him, and I want to thank Dr. Samir, both for generously giving their time and being a part of this program with us all today. Hey, Matt, how are you? Haven't seen you.
How are you?
Yeah, I'm doing great. It's good to see you. I haven't seen you in a while.
It's been a little bit.
It has been. You've been doing a lot of traveling, a lot of organ harvesting, and running around a lot of different places. So hopefully things are going well for you there.
They are.
In Nashville, yes. So, so real quickly, I wanted to ask you one question. This clinician that I know forever, Sweet Hedricks, and she's a wonderful perfusionist, wonderful person. I've known her for a number of years, met her down in New Orleans at our conference. But she did add, after we had answered the questions before about heparin load for COVID, she's seeing using 100 units per kilo rather than 50 units per kilo on VV, and are we seeing this? And again, my answer is we go by APTT. We give a loading dose and then we let it come down. We usually start them off. We probably start them off at, I would say, 50, and then we adjust from there. But what do you see, Matt and Dr. Samir? Let's start with Matt. What do you think?
Well, fortunately or unfortunately, we have yet to put our first COVID patient on ECMO at Vanderbilt. And so that's a blessing, but the reality is we've been in contact with a lot of different places, and they're using a 50 to 80 APPTs or APTTs as the range. And in the presentation I have, that's one of the sections I cover. But yeah.
Dr. Samir, what about you?
You just follow the heparin protocol, and if you're having a problem, then you just make sure look at your antithrombin 3.
But do you do 100 units per kilo right off Jump Street with your COVID patients, or do you start with your regular heparin protocol and then adjust up from there if you need it?
Regular heparin protocol, adjust up.
Got it. Okay, good.
Yeah, you have to treat like a regular patient and just follow your anticoagulation protocol, but you may have to look at your antithrombin 3 aggressively.
Absolutely, I agree with that 100%. So, Matt, I'm really excited to hear this talk, and I'm surprised to hear that you have still not had a COVID patient on ECMO. We have had two here in our part of Houston. I know the medical center has had more, but I'm really fascinated to hear what your experience has been, because I know you've done a whole lot of research with this too. But we're really excited, and I'm really interested to hear how it's gone for you, and I'm just grateful for you. So it's for the good that you have not been inundated with those patients. I'm happy for you if that's the case.
Yeah, it definitely has been. I think there's been 3 patients in all of Nashville that have gone on, COVID positive patients. And like I said, unfortunately for us, for sort of experience, but very fortunate for the whole city, that we've only seen 3 patients get put on.
Mm-hmm. Mm-hmm. Excellent. Well, that's good. And actually, that was part of my talk earlier. We have seen, even in Houston, a lot fewer that have gone on ECMO than I had ever expected. And that study that Dr. Samir showed, though the number was high, 549, I think that was worldwide. Was that worldwide? That was
Absolutely,
that was
sir.
all
Yes.
that was all ELSO registered places.
Yes.
So that was worldwide. That's actually a pretty low number of patients who have been, where ECMO has been offered as an option. And I'm not sure the reason for that. You may be able to elucidate that a little bit, Matt. So let's go ahead forward with your slides, and then we can have discussion afterwards.
Sounds great. Well, like I said, this is more of a compilation. Every Friday morning and evening, we've had for the last 4 weeks, we've been lucky enough to have a call, an international call and a domestic call with multiple different centers across the country and world, that we've talked about, more or less outline the COVID strategy, or how to treat these COVID patients, whether it be before ECMO, during ECMO, and even after ECMO. So that's kind of what I'm going to try to put together today as a compilation of what we've talked about. So we'll get into it. Next slide. And so the reality is that it's not a matter of if you're going to see this, it's a matter of when. We know that this strain or this virus has had multiple strains already. We've seen that with the reinfection of some people that have already been, quote, had a positive test. They're 14 days out, their viral load is completely gone, and then they get reintroduced. We've had that in the Paris experience, and we've had with Italy and Japan that we've been talking to. We've seen that. So there are, it seems like indication is that there's going to be multiple strains of this. And so if, this may happen again this fall, and unfortunately may even happen up to next year with different strains of this particular coronavirus. Next slide. And so, I kind of wanted to get a little cheeky with this, but it is good to have friends in low places. And, if anything, a lot of times people, even in the medical community, so as much as we share things, there's a little bit of, your special little sauce on things. That has not been the case here. People have completely come forth, right, with anything that works for them, anything that doesn't work, and really thinking outside the box. There's been no, suppression, what I would say, of any kind of novel idea or a strategy when thinking about this. So there's a lot of things that have been thrown at the board and say, hey, what do you think about this? There has been quite a bit of discussion, and then some people just said, well, we just probably need a small trial, and what they're looking at is putting between 6 and 12 patients in these little, what I want to call sidearm trials that they're doing. A lot of that is happening in Paris, and a lot of that is happening in Japan. And so for the most part, there's a gentleman, Jan Schmidto. He's from Hanover, Germany, and he actually did some of his medical school at the Brigham in Boston, and he's actually been over in China since February 7th. He's been at the Peking Union Medical Center College Hospital, and he's been there since February 7th. And so to play out the whole spectrum of what we've seen, he has seen it from what I want to say from the beginning, and now he's, they're almost past the curve, and so he's probably got the most experience with ECMO patients as far as a continuum of healthcare. He doesn't have the volume, but he does have the continuum. So this is his recommendations personally, and of the treatment. He says early intubation and the probing and proning and early ventilation and tracheostomy is actually the way to go. They see that if you don't let the lungs get so beat up, and they've almost they've called this a self-induced acute lung injury, and I've never heard of that before, but it's been talked about a lot, where it's actually it's your own inspiration and respiration trying to keep up with the body's demand of metabolic, that you're actually hurting your own lungs just by trying to keep up with it. And so what they're recommending is that early onset of intubation, sedation, and paralysis, and just trying to not let their own bodies beat up your own body beat up the lungs. He moves on and talks about don't expect too much from the antivirals. Whether it's hydroxychloroquine and azithromycin, whether it be lopinavir. He says that the problem is that with putting these antivirals in, there's it doesn't really help unless you get the early administration, kind of like what we see in Tamiflu. And a lot of the times your viral load in these patients are so low it's undetectable, but the virus is still in the patients because upon autopsy they can find the virus trapped in the lungs, because they're generally trapped in immune cells in the tissues where your antiviral agents can't really get in and really kind of do what they're designed to do. The inflammation process and the cascade storm, I'm sure everybody's, maybe if you're on any of these calls, that is 100% what everybody's seeing. These patients are they're dying and they're becoming critically ill and severely, more or less, their end organs are getting attacked from this cascade storm. The inflammation cascade storm. The pros and cons before using any kind of anti-inflammatory agents, or even there's even been some talk about doing some like some immunosuppressant drugs or even immunomodulatory drugs, kind of like we see with like heart transplantation, whether it be cyclosporine and some of those other things. The problem with that is that it's not a free lunch, because the downside of using those drugs, when you do get out, because those drugs have a long half-life. And the reality is that you can end up, because these patients are not going to come out of the hospital soon, you end up getting the downside of those drugs, which are ventilator acquired pneumonias, hospital acquired pneumonias, and then when you get into you're talking the MRSAs and the really nasty infections that just hang out in hospitals. Those people end up succumbing to those. They don't die from COVID, but they'll end up succumbing to a post-COVID infection. And so there's not a free lunch when it comes to those antivirals. There's been some talk about using some interleukin-6 suppressors to try to stop the process. The problem with that is they don't know if it's upstream by interleukin-6 or it's downstream. And so really taking that out of the equation, it does the same thing. It's setting you up for a problem down the line. In the beginning, they're suggesting low dose steroids, but only until they're intubated. If you can get by with it and giving people low dose steroids to kind of suppress what's going on, but once they get too sick to where they have to intubated, they want to stop all the steroids. More or less, the disease process is going to progress, and the steroids aren't going to help you. That's what they found. Moving on to the coagulation, we talked about this briefly before. Coagulopathy is quite common in these patients. They've seen gangrene of the extremities from your microclot. It may be part of a DCD process. It may be just from an upregulation of an more or less of inflammation process, similar to what you see in trauma patients, your typical trauma patients on ECMO. We see that at Vandy with our trauma patients, that sometimes you have to do the range of the 50 to the 80 on the PTTs. But that we haven't. The only hospital I know that is using anything other than heparin is hospitals in Georgia, around the Atlanta area on ECMO. They've been using bivalirudin. That's the ones I've heard consistently. And then Dr. Schmitto talks about your ventilation strategy. He says that you have to. It's a completely different pathophysiology than your typical ARDS patients. You're seeing really good compliance, or he's seeing at least good compliance, lung compliance in these COVID patients. He just is suggesting low tidal volumes, low plateau pressures, and low PEEP. Definitely not high PEEP. He'd rather give people a higher FiO2 on the vent than higher PEEP. And that's kind of the results that they're suggesting, that they're getting some of the best results and getting people out off ECMO, off the ventilators, and full recovery with that strategy. And I guess there is really no magic bullet. It's more or less we're only seeing this as people are supportive care, providing weeks up to a month of supported care throughout the hospital. And the stratification between the patients that he's seeing and really typically what we're seeing at Vanderbilt is that, your mild cases people are test positive. There's about 5% of them that are mild. They really don't even need to be in the hospital for the most part. They can come in, get checked out, and we're moving them on. There's some moderate to mild cases. We're seeing about 25 to 30% of those. They may come in, get a little bit of supplemental oxygen, and then they're actually moved back out, back into their homes within a couple days. There's some moderate cases. We're looking at 30 to 40% of those. Symptoms are positive. Their CT, their chest X-ray, you can see that the signs of COVID, the typical signs. Those patients, they will. Vanderbilt has been starting those prior to intubation, a low dose steroids, but once they declare it intubated, we don't use the steroid anymore. And then the severe cases, we've seen about 20% of those. And what I want to say about 20%, if you end up being on a ventilator, we're considering you that's a critical case. So we're seeing about 20% of our total population going on a ventilator at Vanderbilt. Next slide. So I've kind of done a corresponding, I guess, outline of everybody that we've talked to over the last 4 weeks, and it's just kind of an international discussion. I do want to say Dr. Elaine Combs of Paris at Petit Hospital, he's been very instrumental in trying to not only consolidate the information, but he has one of the largest, I guess, populations that we can actually get some of this information to everybody. Paris, before this hit, Paris had I think it was 1,200 or 1,300 ICU beds in the greater Paris area, about a 30-mile radius. At one time, it peaked, I think, April 9th. They had 2,700 intubated patients in Paris and over 200 patients on ECMO. So they really have a large patient population that they can extrapolate some of the data, what's working, what's not. And he's been so generous to distribute all that information to people on these calls. Spoke with him as of last night. They currently at his hospital had 45 patients ECMO cannulated. 96, 97% of those, I think they had 2 VA patients on. The rest were VV, traditional neck groin cannulation. He's been proning 75% of his ECMO patients. He just finds that the proning actually gets a better result. So if they can be prone, what's really limited those is the number of beds that they have that are able to prone. Their mortality rate's about 15%. It is a little too certain to see how it's going to look, but he's hoping that there's at least a 50% mortality and survival of maybe up to 70%. But it's too early to call for him. He goes, we just have too many patients that are still in the spectrum of healthcare in their process to get a good number of what it's going to look like. As of last Friday, Japan, I take that back, 2 Fridays ago. So 10 days ago, Japan was getting worse. Their number of infected patients tripled in the last 2 weeks. So they have not peaked yet. They currently have about 75 patients on, and they're seeing the same type of mortality rates early. They do have some people that are on the back side of the curve as far as the more or less the transition of being infected, the inflammation storm, and now the recovery. But they still have a lot of patients that are being infected there. Dr. Mozami up of NYU, he responds to the call on every Friday as well. They're seeing right now, as of last night, there was 22 ECMO patients in NYU. That's currently. They've had a lot more than that, and they've decannulated a lot as well. Once again, everybody's just a little bit, I don't want to say pessimistic, but they just don't want to, they don't want to say that we've got this under control yet. They're really, really hesitant on declaring what kind of numbers and what kind of outcomes they're going to have. No one's really ready to speak forward about that. We haven't heard much from Boston. They're in and out on the call, but they've had over 100 patients intubated with COVID. And this was from, they weren't on the call yesterday, so this was from 10 days ago as well. And they figured that if they were going to get a surge, it was going to be last week. So they weren't on the call yesterday, and so I'm a little anxious, and I want to see what happened this last week in Boston. Next slide. So Chicago, although they've seen a lot of COVID patients, they haven't really reported too much of how many they got. This is at Rush, and so we didn't get it. They weren't on the call last night either, or yesterday morning. But once again, 2 weeks ago, they seem to have good experience, and it's funny from what we see at Nashville. We're not putting patients on ECMO. We're being able to manage them, with early intubation. But Chicago does have quite a few people that are on ECMO, according to the call 10 days ago. Philadelphia was on the call yesterday. They have about 35 patients on ECMO currently. I'm sorry, they put 35 patients on. They have had two deaths, but they think they're going to have a positive experience with with more or less the adjunctive therapy of ECMO on top of any other strategies they're doing. I'd like to come back to Philadelphia at the end of the talk. I didn't really want to put a slide together about it, but it has to do with the CytoSorb. It's a filter that we can talk about after the kind of offline as a discussion. And then we really haven't had any ECMO patients in Nashville per se. We've had 3, none at Vanderbilt, but we are intubating people early, and I would say we're traking people on about day 5 to 7. That's kind of the strategy that we're doing. It handles the secretions better. We can kind of deal with their heavy secretions. It's able to get them in and out. So we're trying to not let people turn into a multifaceted thing like with a pneumonia on top of the viral experience. UCF has said 0 patients on ECMO. They're pretty much like Nashville. They kind of mimic what we've got going on, or we mimic them on the calls. They really don't have much discussion about it, but they're on the calls weekly. Seattle has a long-term outcomes, and of all the people, they're kind of holding. I think they're getting ready to write a paper, come up with a published document of what they've done. And so if anybody, they haven't been the most transparent, and that's not to say that they're not adding to the conversation. It's just that their numbers. I don't know if they don't have a good feel on what the whole city's like, because it's multiple people within that city that are reporting on this call. And then the Cleveland Clinic, very similar to what Chicago has as far as how they respond. They've got positive ECMO experience down there. They've had a handful to a dozen on, but it's too early to call whether if they're going to get a fully recognized mortality to discharge. And next slide. And so the big takeaways as far as from an ECMO management strategy, kind of swinging from just total patient care to now that we've decided to put them on ECMO, what people are doing. They're putting large cannulas in. They're suggesting large cannulas. Once again, this is not personal experience for me, so I'm just regurgitating what the calls have been like. The PTTs 50 to 70, 1.5 times to 2 times the normal rate. They are seeing multiple oxygenator changeouts, but what they are not seeing is this huge SIRS effect, like you may see from time to time on normal patients, and they probably think it's because the upregulation of the inflammatory process is already at a peak with these patients. So if you're at 100%, or if you're a high number percentage-wise of what you've been up-regulated on your inflammation, putting another oxygenator to re-expose you to another foreign surface, you can't get any higher, if you will. They're not seeing a big surge response with the oxygenator changeouts. And once again, the general vent strategy that I've talked about, driving your pressures 10 to 12, peak no more than 10 to 15, and proning patients, and it especially works with patients greater with BMI of 30. And so that's really what I've got as far as slides. I wish, like I said, as far as a presenter standpoint, I wish I had more personal experience. But from a clinician and from a person, from Nashville, I'm glad I'm not seeing that. And so that's what I got, Joe.
Yeah, me too. I'm glad you're not seeing it too. But I think I think there's something in there that is latent, if you will. Why are you not seeing it? It sounds like you have patients. Yeah. You have patients. I don't know. I mean, you may not have as many. Okay, that may be true, but it doesn't sound like the number that you have is so different, where you have 5 versus somebody else having 500. It's not that large of a disproportion. So the question is it the vent strategy? Is it the early use of the vent plus the ventilatory strategy? Is it something to do with how they're being medically managed with various medications, whether it be antivirals or whether it be something else? You talked a little bit about the anti-rejection medications that were given, but there's consequences to that long term, which I think you discussed. But why? So Dr. Samir, Matt, I mean, maybe either one of you can start this off, but why are we seeing so many more patients over here? And UCSF is not a small place, and they have plenty of patients. Nashville's not a small place. Vanderbilt's not a small place. They have plenty of patients. Why are we seeing such a difference between place 1 and place 2?
I'll tell you, it's a public health issue. I mean, there's clusters or no clusters. I feel like there's parts of the country that have clusters, like New York. I mean, I think we are in the medium range. California has locked out. You know what I'm saying? So I think it's a public health issue. Why? I'm not sure why.
So are you saying it's socioeconomic? Is that what you mean by a public health issue?
Yeah.
Okay. So
I mean, you know that in New York, people are overcrowded. There are a lot of people living together in the same apartment, and that increases the spread, obviously, for sure. That was the problem with New York. That's how Montefiore and Elmhurst got run over. They are in an area that I'm very familiar with that's highly overcrowded, that there's no chance of social distancing.
Well, I'll tell you that here, when we went through even just last year's influenza seasonal outbreak, we saw many more patients who needed to be put on ECMO. They had clear indication. And I just find this to be a fascinating question, because those patients that we had were also, it's the same socioeconomic strata here, whether it's this or that, where I'm in the same place. I'm not changing my location. And so I saw a lot during the H1N1 epidemic, saw a huge number. And now, really, I mean, with this, I've seen 2 the entire episode. And I don't know how much.
I have to tell you something. Now, I think you're pushing my buttons, so I'm gonna have to be a bad boy right now. Okay, I have to tell you, and this is not to say that we are the best. There's nothing. You know, Texas is very aggressive. The Med Center has more than two, Joe. You know that.
Yes. I know they do, but
we have a lot. We have people that decannulated and gone home.
But they're not inundated. They have more. I don't disagree, but they're not inundated. I mean, they're not.
No, but nobody thought we were going to be inundated with ECMO. Nobody thought there was going to be an inundation with ECMO. To be honest with you, the inundation was all about the ventilator. It was never thought about to be the inundation with ECMO. Because again, it's still a precious resource, and you triage who you're putting on ECMO. So I think it is the ECMO experience is as we thought it was going to be. I don't think we're underestimating what happened or overestimating. I think whatever patients on ECMO in the three hospitals, in the three systems, the Med Center, they are the ones we thought they're going to be. I don't think there's under or overestimation. I think, I don't think it is any. I think we have just low threshold putting people on ECMO. And that, you know, I agree with 100%. Other people don't do that, and that's fine. I mean, and it's related. We have been very progressive when it comes to MCS, and whether that's right or wrong, it does not matter. I mean, that I will have to say.
Well, Matt,
I would agree with him. I think it is. It's based on your threshold and your comfortability. I mean, the other thing that, to your point, when you talked about socioeconomic, Joe, I don't know if it's if I want to use that term, but what I have thought about, you know, Nashville does not have a public transportation system other than buses, and you know, with this being as contagious as it was, and to the doctor's point, people were on top of each other in New York, in Chicago, in Paris, where public transportation is a huge thing. Italy, Japan, all these places that you're seeing these large outbreaks. And I'm not saying that, you know, any outbreak isn't significant, but I don't think we've seen the end of it in Nashville. I think we're going to slowly. So we had the most patients we've had was 32 in the hospital at one time, but we've had no less than 25 ever. And so as people come in and people get discharged, people come in, people get discharged. Our line has been flat when it comes to the amount of patients we've seen in the hospital. But and the same way on the vent patients, we've had as many as 8 ventilated at one time, and as low as 4. And that's been for weeks now. And and it's, you know, people are either you know, transitioning out of the hospital, surviving. We have had some deaths. We haven't had a lot of deaths, but to the doctor's point, I think we decided at the very beginning, because we only had, we only had to have the capacity of having 17 ECMO patients at one given time. And so I think we were going to try to hold back on that resource. Only because we felt as though if we pulled the trigger early on that, we may inundate us with where we're going to have to make a decision on, when you get down to your last 2 ECMO circuits, are you going to go, well, who needs to really be put on? And because it is a known valuable commodity. It is not, you can't make more ECMO circuits overnight. I know you can't make ventilators overnight, but ventilators are a lot easier to come by than ECMO circuits. Let's just put it that way.
I agree. Well, I agree with you 100% on that. I really liked, Matt, what you said about collaboration. I wish, and I understand the competitiveness. I like the way you had said it, and that how this has sort of washed away that inherent secrecy, and it's very open and collaborative. I think we need to be more like that in a lot of different things. And when I say socioeconomic, look, I mean, I think I believe it's commonly understood that, you know, people that are in the lower economic strata tend to have poorer diets. They eat things that are unhealthy because they're easy, convenient, inexpensive, fast food, McDonald's, Burger King, and so forth. Their obesity rate is much higher. Dr. Samir had a slide where it showed that patients that succumb to COVID are very, very high rate of mortality when you add obesity into it, much more so than if you have any of the other known comorbid conditions that increase mortality with it. Obesity was number one, had the highest degree. And I think that unfortunately that's something we see not infrequently in that group of people. And I think that Nashville is a more, I think, affluent, San Francisco is a more affluent, Houston may be a more affluent society than some of those places, not every place clearly, but there's a larger percentage of people in New York, Chicago, Detroit that are not as affluent, that fall more into that category. So their percentage, I think, is a little bit higher, and just the sheer volume of those people is a little bit higher. And that's an opinion. I'm not 100% sure, but that's what I would hypothesize. You know, earlier treatment, they tend to not seek health care as fast. And so I think that, you know, you're treating people earlier. I think that's going to make a big difference. I am confused about something, and I hope you can clarify it, because I do want to hear about your discussion on the adsorption filter, CytoSorb, because I'm very interested in this. But you had said there were multiple oxygenator changeouts. Now, notwithstanding, your point, I think, was that they're not seeing the cytokine bump up that you see when you change an oxygenator and add an artificial circuit into the mix, because they're already peaked, as you said, with their cytokine storm or inflammatory processors. But why were the multiple oxygenator changeouts? That's the part that I want to know.
Well, in the beginning, what they were seeing, and this is from the Paris experience, is that they were using their normal, more like coagulation, just normal coagulation. Until they realized that these people are a little more coagulopathic, then they had to keep bumping it up. But what they did find, that they were so concerned, they were like, you know, this is going to put people over the edge, changing oxygenators out. They didn't see that result. It was what you would typically see on an oxygenator change out. So they're not changing oxygenators, and maybe I misspoke on that, or wasn't really clear in the beginning before they realized that they had to use a higher PTT. They were going through oxygenators a lot quicker.
Yeah, that's a good point. I just wonder, though, whether or not we're misinterpreting clot for perhaps because of this inflammatory storm, this cytokine storm, that we're not clogging versus clotting the oxygenator. And that's why you're seeing such decreased efficiency. The question that I have for you is, do you routinely measure intra-oxygenator blood volume? Do you use that device that's made, I think it's made by Transonic, and it's called the ELSA-meter, and you can measure intra-oxygenator blood volume with a 20 cc injection of saline? Are you familiar with it? Do you use it? Do you think you should use it to differentiate between clot occupying your oxygenator versus, unless you see it, of course, versus it being clogged, the pores, by inflammatory mediators that may be adhesing to the oxygenator fiber material?
Sure. If I am briefly familiar with that. I think we're going to have someone come in the next month or so. As soon as we can have open visitors, we had a plan to get some people in there in March, and with this happening, we weren't able to get that device in there as quickly as we'd liked. But if I know the device we're speaking about, it's where you inject it, and it's almost like a fixed law, almost like the old thermodilution ones, where you could figure out exactly what your based on your flow rates, what your volume is in the oxygenator. Is that correct, Joe?
That is correct, yes. And you should have called me. I'd have brought mine and come done it with you. But it measures intravascular blood volume as well. I mean, intraoxygenator blood volume. So you usually get a baseline. But if you know what if the data sheet tells you what the specs on the oxygenator, if it holds 210 cc's and there's 210 cc's of volume there, then you really don't need to have done a baseline. But it's good to do a baseline if you can, and then you can measure it serially, every day or whatever, and see if you're starting to see a reduction, which would theoretically be it's being obstructed by, it's being occupied, the space is being occupied by clot. And it's really interesting. It's some very interesting data with it. But on VV ECMO, it also measures at the same time with the same injection recirculation. So it'll give you a percentage of recirculation and an effective ECMO flow, so you can do both. So VV ECMO does both, but on VA ECMO, it's only going to measure, obviously there's no recirculation, it's going to measure intra-oxygenator blood volume. It's a very useful tool. I really highly recommend it for anyone. I kind of wish that I'd been able to come up too, because no one has talked about, and Dr. Samir, you may have some thoughts about this, but no one has really discussed the use of microcirculatory visualization in these patients in its determination of treatment modality benefit or in predicting survival. What do you think about that?
Because people are looking at it as a respiratory shock stage, not a high hemodynamic shock stage.
Mm-hmm.
I mean, you're not really using hemodynamic support for those patients.
Mm-hmm. So you don't really see any use for it?
No, I don't think so at this point.
Mm-hmm. Okay. And then I guess too, let me see, there was that. What else did I need to ask? There was something else I wanted to ask, and of course, I'm having fleeting memory issues, okay? But it'll be interesting to see how this all plays out. Let me let you two sort of add some, I know what it was. Matt, you said something very very dear to my heart, and I really want to hear about it now, and that is on the CytoSorb, because I have some information on that too, and I want to know what your thoughts are on that and why you feel the way you do. Dr. Samir, I want to get your thoughts on that, and then I can add some of my thoughts at the end.
The only two, I've got one on the interviews that we've been having. Paris has used it a handful of times on their patients. They're not using it except for once they get to a full-blown septic state. The cost in U.S. it's now approved for compassionate use, emergent use, whatever the verbiage is. It was not an FDA approved thing. It may still not be, except for compassionate use. They're costing U.S. dollars about $1,200 a piece. Linda Mongero had a great talk on that a couple weeks ago on a conference call. What they are doing in Paris, and what I've seen or I've heard what they've done here, is they're using it in line, kind of like a CRRT, for 12 to 24 hours at a time. It does reduce all the cytokine, all the interleukins, but you have to do serial tests on them. And then what they're seeing, unfortunately, is after 4 to 7 days, you get the if they're still on ECMO, you get the return of all that. And so it's almost like a re-up of the same things. And so every 4 to 7 days, they're having to put another one of these in to more or less, if you will, filter out all that again.
And you're saying it's $1,200?
What I've been told, it's $1,200 per filter.
And you use a filter for 4 to 7 days?
No, use the filter for 12 to 24 hours.
12 to 24 hours, okay. And
it works. What I've been told is within 4 to 7 days, if you're monitoring the serial testing of the cytokines, and you'll see it 4 to 7 days, it'll start ramping back up.
Mm-hmm, mm-hmm.
And so I have very limited experience. The Paris group, they're only doing it as if you will, a Hail Mary on the septic patients, because Dr. Combs, he's looked at the papers on that, and he says, I'll quote him on this. He says, the evidence is very weak at best. Mm-hmm. These patients, because I think what happens is that you can filter it out, but it just comes back.
Mm-hmm, mm-hmm, mm-hmm.
That's what I know about it.
Yeah, that's interesting. I'm really interested to know more about, I've always thought that it made sense why it's re-emerging. Of course, I don't know how much of that is due to it not being, to the issue not being necessarily addressed properly. Clearing it makes sense, but you have to have a reason for it to then, reemerge, have a second wave, if you will, of cytokine storm, because that's generally going to be due to some antigen that's causing that to happen that has not yet been cleared. So it doesn't really it makes more sense to me to do it than not to do it, but based on what you're saying, I can understand where that would be. That's an opinion of mine, and again, the evidence may not be there, which is a different issue. There is another device, just so you know, that is FDA approved under an emergency basis, though, so I will make that point, for COVID-19 patients, and it's made by Baxter. And if you do CRRT, which I'm assuming you do, and I don't know whether you use the Prismaflex machine or what machine you use, but they have the Prismaflex and the Prismax, but they're the only company right now that does CRRT that has this available, and it's called the Oxiris, OXIRIS. It's been used very successfully in Europe, and now it is FDA approved here for use, and it's basically a CRRT filter. It's the same exact filter set, but it has a special heparin type bonding to it. Of course, that'd be a problem if you had hits, and it's obviously contraindicated if you do have hits, but it's an adsorption filter, a little similar to the CytoSorb, but this is just a more simplified version perhaps, and it can also perform CVVH, I think, simultaneously. So you have double benefit, and it is proven as a clearer of the evil humors, if you will, the interleukins, the complement, the TNF alpha, all that stuff that we want to get rid of. So that's available on the market also, and it's by Baxter. But it's called it's the Oxiris, OXIRIS. I don't know if I'm saying it right, but it is FDA approved for emergency use or emergency approval authorization for blood purification, specifically for COVID-19 patients. So not patients who are septic for some other reason, but for COVID-19 patients. So I wanted to pass that information on to y'all. Dr. Samir, what's your thoughts on all of that?
I think right now, to be honest with you, in my opinion, the only thing that you have to triage your resources. So if you're on ECMO, I think continuous CRT is the way to go at this current time.
Well, I finally, I have drugged you kicking and screaming.
But all that, we discussed this privately, why you cannot put everybody on CRT. We discussed this.
Yes.
You know we did.
Yes. But
Okay.
it drives me crazy when people say, oh, well, you're going to be adding another machine and you're increasing risk. And Matt, I want your opinion about this too. And I'm like, the patient has got 8 IMED pumps, it has a rapid transfuser, and is on ECMO. And you think adding a CRRT machine is over the top? So that's, I'm like, I think, Matt, my view is every patient on
resources.
Yeah,
resources.
my view, Matt. Yeah, exactly. My view is that every patient who is on ECMO should be on CVVH. I think it's just really good for maintaining acid-base balance, electrolyte, basically homeostasis, and not cheesy CVVH, not just continuous dialysis, but actually convective clearance. Because we do need to remove plasma-free hemoglobin. We do need to remove some of the larger molecules that you just can't do with straight diffusive clearance. So what's your view in Nashville? What do you guys do?
We're using CRT quite regularly. I mean, as we all know, acute kidney injury is one of the first things that happen. Whether it's due to blood pressure, whether it's due to just sickness, but most of our ECMO patients do end up on some sort of CRT. I would say about 75% of them,
Mm-hmm.
Where I find there's a little bit of we'll say mixed opinions within our institution is whether that you hook it up to the actual ECMO circuit or you use a traditional VAS cath in the patient. We have a different model to where the perfusionist is in-house 24/7 hovering over all the patients, and we've got bedside nurses that are and nurse practitioners on the floors that are taking care of these patients, but they are not the ECMO machine experts. And so anytime you introduce another machine into the circuit to where you have a chance to entrain air, I get a little nervous. So I'd much rather, and you can entrain air just as well, through a VASCATH if it's positioned, and you leave it open.
Sure.
But anytime there's a CRT circuit on my ECMO circuit, I always find it's a little more, it makes me a little more nervous. I'll just put it that way.
Me too. I can't dispute that. But of course, if it's a secondary, consideration, and you don't have, any other place to stick anything.
Yeah, you have to do what you have to do.
And you don't want to stick the patient for fear that you're gonna hit something you didn't mean to hit, even using ultrasound. I've seen it happen.
Sure.
And you don't want to have, a vessel that's been an artery that's been perfed. I don't know. It is a judgment decision, certainly. And I think we have the luxury of we're at the bedside, 24/7. We're only dealing with usually one at a time at any one hospital. So I think we have that luxury, whereas I think when you're dealing with multiple patients and codes going on here, you got to get to a different floor, and depending on other people like that, it would probably make me a little nervous too. I probably would feel differently than I do at this point. But I'm a big believer in it. I think it's an understood and underutilized and a frequently improperly utilized tool that I think should be used more often in more of the right circumstances. Because I do think it has a place, but it's a very specific it's a specific place that it belongs. And I think that I just find that its application is not utilized to its full potential, and frequently it's used when it really shouldn't be used. And then you have, marginal or at best, very, inconsistent outcomes, and it makes the whole therapy not look that good. But that's just my opinion.
I will comment one other thing that it kind of made me think about this. When Dr. Samir said that that ECMO is a finite resource and how we pull the trigger. And I can't remember who was on the call. It was one of the U.S. places. I almost want to say it may have been NYU, or it could have been Philadelphia, that said that was going to be one of this was 3 weeks ago, that was one of their contraindications. If the patient had to be on CRT, they could not be on ECMO as well. And now they've come back. Now they've come back since then to change that. What? But in the very beginning, I think to more or less to Dr. Samir's point about pulling the resources and knowing it's what resources that they were gonna. They didn't want to throw what they felt was good resources after bad, if you will. And so they've retracted that, but that was a big discussion 3 weeks ago, early on.
Yeah, that's very interesting, and I think that comes from, Matt, I'm really glad you said that, because I think that comes from the mentality, and Dr. Samir, I do need you to elaborate on this. It comes from the mentality that the patients are only put on CRRT when there's no other option. They're so hemodynamically unstable you can't dialyze them. You're in a futile, almost futile situation, and we're just going to throw CRRT at them. But my way of thinking about this is we see much better results. You're seeing it with early intubation, not waiting, not letting the patient suffer with relative hypoxemia and struggling to breathe. With various different other mechanisms, BiPAP or just high flow oxygen. So venting them early, tracheing them early, putting them on ECMO early, and I believe putting patients on CRRT early, all lead to, at the end of the day, better outcomes. But I understand, and again, you know, I know Dr. Samir will point this out, and it's true, you increase your exposure to criticism that you put those patients, you tube them too soon, vented them too soon, trach them too soon, put them on ECMO too soon, use CRRT too soon. Those patients could have done fine without any of that. That's what the exposure risk is that people will criticize you about. But when you look at every data, every data set that I've ever looked at for my entire career has always showed much better outcomes with earlier intervention than late intervention.
That's true. I mean, you see much higher mortality and morbidity with late intervention. You intervene late, you're past the point already. You should not intervene, you should leave things alone.
Mm-hmm. Yes, I agree with you, but we don't. We use, I've seen it before. Matt, I don't know if you've seen it in your, maybe you might not see it at Vanderbilt, and of course, Dr. Samir, you're not going to see it down at Texas Medical Center, but I can assure you I've seen it in the community-based hospitals where we have used, I have seen CRRT and ECMO both used almost as palliative care. And it just makes no sense to me whatsoever, but I've seen it happen.
I don't claim to comment on and know about CRRT, but I think historically, because ECMO had a stigma, kind of a stigmata that it was, we're talking all the way back in the data back in the early 80s.
Mm-hmm. LVADs.
Of that, ECMO was pretty much a death sentence. Well, the reality is because I think back then the technology was so bad, and as far as the oxygenators, the coatings, everything that technology has brought to us to 2020, when we were trying to use the same physiologic and physics principles with rudimentary devices, I think that was too much to overcome, even in the patients that were survivable.
Mm-hmm.
Absolutely.
And I think as we've gotten this farther with technology, that stigmata has come with us, is that ECMO is still at best 50-50. That's the mentality. And really, to be quite honest, ECMO, when utilized appropriately, is much higher than 50-50.
Absolutely. For VV, it could be as high as 70%
Sure.
survival. For VA,
Sure,
it could be as high as, depending on if it's a cardio, like you gave that talk recently on the experience in Paris, where you drop dead in the grocery store and you're having and you're under CPR. Your chances of surviving was in the single digits. And with their ECMO program, they've gotten it as high as, what did you say, 18 to 22%, or something on that range?
It's over 20% now.
That's huge.
And you say that's it's still 20%. It's much better. It's 3 times what your single digit. I mean, it is.
Yeah, you can't argue the point. I mean, as far as I'm concerned. Okay, so let's do some final thought if we could. So I'm going to start off with the most esteemed of us all, Dr. Samir, and ask you to sort of impart to our audience where you think all of this is ultimately going to go, specifically regarding COVID-19 and whether we'll see a resurgence in the winter, what you think's going to happen, treatment-wise, vaccination-wise, the whole gamut.
Okay, so I will have to say my little political statement, which political and clinical. I think right now with pushing to open back very quickly, we're going to see a resurgence earlier than the winter. And the resurgence, I feel, is going to be worse than the initial wave because we're getting relaxed. Things are doing okay. People are going home where they're not dying. We're seeing much with a positive outcome. Now we're getting a little too comfortable. The only thing, Matt, I'll tell you, I disagree with you with one thing. And if you or Joe come under my care, I will start you an antiviral right away. I'm a big believer in antiviral.
Okay.
And I'll tell you, and I've been a big believer in the beginning. But the studies have been showing that, and I don't have any stock in remdesivir. That remdesivir, you start early, the patients are going home much quicker. And I agree with the superimposed pneumonia. So you have to go back to the old-fashioned way. Start remdesivir and start Vanc and Zosyn.
Okay.
I unfortunately, I know somebody I work with that got the superimposed pneumonia. The superimposed pneumonia was worse than the situation itself. So you really have to worry about the superimposed pneumonia early. So I do feel the antiviral is going to have a huge role. Vaccine is coming, but it's not gonna. It's gonna take a while. That we have to be very careful with, because that's something you don't want to start inoculating the whole population, unless with something that could be harmful or not useful. I'll tell you, remdesivir. Any antiviral, but I've seen remdesivir because we're part of a study. I have told the study coordinator, I got hospitalized with COVID-19. I want to be on remdesivir. So this was like a preemptive strike for me in case I got sick.
But you want it early, right?
Yeah, I want it early. Yes, absolutely.
That's
and the company has expanded its criteria. There was a limitation from the FDA. The FDA loosened up things, and Gilead loosened up things. So the expansion of the criteria right now. But you do have to go apply for compassionate care, like Matt said. You have to send an application. It's not automatic.
See, I think what a lot of people don't understand, Dr. Samir, is that the whole idea of the antivirals, from what I understand, and of course you could correct me if I'm wrong, but you want to control, you need to control the viral load to avoid the subsequent cytokine storm that comes from the viral load being out of control. Do you feel that's correct?
It's kind of, you're trying to block the viral load from getting into the cell. That's basically the concept. You're blocking the virus from getting into the cell.
Right. Okay. So rendering it inert.
Exactly, and that's the whole premise of the situation.
Okay.
So I believe in that. So I think I ask everybody, if you don't care about yourself, I'm okay with you not caring about yourself, but you need to care about Joe. You need to care about Matt. You cannot be exposing yourself and then expect Joe and Matt to take care of you. And I read there's something was on the news really remind me back in the day of Tiananmen Square. This doctor stood in front of the truck in Austin because they were demonstrating for going back to work very early and opening the country. So this doctor reminded me back of Tiananmen Square that they felt that they're being killed by patients exposing themselves and then showing up to the hospital. So I'll tell you, I think we need to be very conscious of this situation. I hope all of you stay safe, please.
Very good point, and thank you. That was excellent. Matt, what are your thoughts?
I honestly think it's the same. I'm going to agree with Dr. Samir, but I think the resurgence is going to be, if we're not careful, people, we're going to have to be careful for quite some time. But these plans that have been rolled out, from the White House, and then I guess it was Wednesday, our governor here in Tennessee rolled out a phase on what we're going to do throughout the state, but then left the 4 biggest counties in Tennessee, the mayors, to roll out. So Nashville's just rolled out a plan that every 14 days, after 14 days of a flat slope on the infection number, that they'll graduate to a different phase. And then in the event, there's an increase in the infection rate, it can either take a step back or it will maintain on that particular phase, and has to do with businesses open, what kind of capacities restaurants can have, whether it's 50%, 75. Bars are not open until the very last phase. And then even at the last phase, they're only at 50% capacity seating only. So there's no standing, there's no interaction in the bars. And from a national standpoint, Broadway's a big thing. I mean, we're second only to Las Vegas when it comes to the strip of what happens down there in honky tonks. But the reality is I honestly think we can't wait for a vaccine. But I do think that if you look at the curve and the exposure, there, to your point, the obese, the elderly, and the high risk are really, really going to continue to have to be very vigilant, and we need to be very vigilant of them as well. I mean, I just think I think it's a dual-edged. Even if it's that we have to do grocery runs for the elderly or the people that are immune suppressed, they don't need to be out, and that's my opinion.
Agreed, and we don't need to go see them other than to drop something off that's been disinfected and let them open the door and take it in and stay far enough away from. I think you're right. We need to protect the most vulnerable in our society, but we do still, I think, have to get our society open. So I'm going to close my remarks with most important is thanking both of you for taking time out of your Saturday, your personal time, out of your lives to do this, because it's so appreciated by me and by everyone else that will watch this video, watching it now, and will watch it later. That's number one and most important. Second is, Matt, do you remember the name of the restaurant that we went to when Stephanie and I were there with you and your wife?
The Cork and the Cow.
The Cork and the Cow? That's right. And anyway, Dr. Samir owes me dinner. And so he's going to be taking me to Nashville to go to the Cork and the Cow, and I'd like to invite you and your wonderful wife to also come. So it'll be Dr. Samir, his lovely wife, Vicky, and myself, my lovely wife, and you and your wife, and we're going to go to the Cork and the Cow and have a wonderful dinner on Dr. Samir.
Because we need to invite Magic and David too.
Yes, Magic and David, of course.
You forgot about Magic and David. I'm here for them.
Well, you know what we're going to do? We're going to go on location, because David loves to go on location, and we'll do a program from the Cork and the Cow. I'll have him bring the live stream box and all of the cameras and everything, because that's something that David truly loves to do. I can assure you of that.
Are you gonna fly us in your little jet over there?
Well, if you close your eyes and pretend you hear jet noise, yes, it's a jet, but it's just got a big fan in the front, and it just spins around and pulls the airplane forward. So yes, I will fly us in that airplane if you so desire. No problem at all.
Please, let's make sure we land in Tennessee. We don't land up in Missouri, or we land up in Portland, or we don't land up in New York.
We're gonna do our best. I have a really good GPS and autopilot, so thank God the airplane flies itself. I don't have to do a whole heck of a lot. But with that said, I just want to thank everybody. And as you know, I get continued questions. If anybody wants to reach out to Matt and Dr. Samir, please just send me those questions. I'll forward them on to them, and they can answer the questions as you see fit. And we'll go from there. So again, thank you again for a wonderful experience, informative and highly professional, and we just appreciate you. That's all I can say. I've said it about 50 times, but I can't say it enough. Have a great rest of your Saturday, and stay safe, and we'll see you all on Monday when we start the Corona 30.
Thank you. Stay safe too.
Bye. Peace.
Bye.
The Point of Care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point of care testing became very clear in our organization. Many of our departments consider the EPOT device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point of care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat, because that's the process. That's just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the epoch that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the epoch device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
Mixed cannulae, expanding performance standards. High-performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Perceval, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP venous cannula and the EZ-Flow Duo. For arterial direct and venous femoral cannulation, the EZ-Flow aortic cannula and the WRAP are available. For venous femoral access, the LivaNova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EZ-Flow Duo cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. EZ-Flow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
Like all perfusion professionals today, we are busy and frequently short-staffed. Does taking time off for a conference create a burden for your teammates? Has reimbursement for your continuing education dropped? Have you priced the cost of going to a meeting lately? Registration fees, airfare, transportation and parking, hotel, and meals out? This totals up to having an out-of-pocket expense of over $2,500. And then you hope the content is good. Perfusion Education has heard your concerns. They have a simple and seamless system that works on any platform, computer, tablet, or even your phone. You can chat during the program or even phone in and be live on the air. The content, second to none. Perfusion Education is by perfusionists and for perfusionists. Create a free account and check us out today.